and go live, no problem. We will be taking questions after every talk.
Yeah, okay.
Talk, we'll take questions and comments.
We're live. You can start, ma'am.
Okay, Renuka.
Good afternoon, everyone. It gives me a great pleasure to welcome you all to Good afternoon, everyone. On behalf of VAPM, it gives me a great pleasure to extend you all a very warm welcome and to introduce to today's academic feast of delicious topics on mysteries of hepatopancreatic neoplasms from renowned faculties and experts in the subject. We are very thankful for the overwhelming response to the CME. I would like to invite Dr. Vaidehi Naik as the MMC observer for this session. And now I request Dr. Prachi Sancheti ma'am, who is VAPM President 2021-22, to deliver the welcome address.
Thank you, Renuka. A very good afternoon to all of you. On behalf of Vidarbha Association of Pathologists and Microbiologists, it gives me a lot of pleasure to welcome you to this interesting webinar today on the topic of unraveling the mysteries of hepatopancreatic neoplasms. The reason for choosing this topic is that encountering biopsies or FNACs or surgical specimens of the liver and pancreas has become increasingly common, even for standalone labs, private practitioners, in addition to institutes. So we thought it was very, very relevant to have a webinar on this topic. And thanks to the digital platform that has got really wide appeal, especially since the pandemic has hit us, that we are able to have as faculty Dr. Avni Pense from the Duke University Medical Center, North Carolina, USA. And also a lot of delegates who have registered with such an overwhelming response. We have more than 300 registrations, not just restricted to members of VAPM, but a lot of them from even outside Nagpur, from Mumbai, Karnataka, and many other places. We are also very thankful to Dr. Mukta ma'am from Tata Memorial Hospital, Mumbai, who has joined us, who will be chairing the next session, and also all our members and team members who have helped organizing this webinar. And of course, the vote of thanks will be given by VAPM Secretary Dr. Ankita Tamne, but then she is of course not going to thank herself. But I would like to congratulate her for an excellent job, because she's been juggling with many things, but has still managed to organize and things in a very commendable way. With this, I once again welcome you all and hope you all enjoy the academic feast. Thank you.
Okay. Now it's time to start with the first talk of the session. It will be my honor to introduce our first speaker of the session, Dr. Avni Pense ma'am, who is an alumnus of Government Medical College Nagpur 98 batch and daughter of past head of Department of Pathology, IGGMC Nagpur and GMC Miris. She is an assistant professor of pathology in Duke University Medical Center, North Carolina, USA, and Associate Director of Proteomics Biorepository and Precision Pathology Center. She is the member of many organizations, including College of American Pathologists, and has a lot of teaching experience, including hepatic and gastroenterological specialty. Many research publications in the international journals and chapters, book chapters also there. And she has many papers and poster presentations in various international conferences to her credit. I welcome Dr. Mukta Madam, Mukta Ramadwa ma'am, who is Professor of Histopathology at Tata Memorial Hospital, Mumbai, and ex-convener of GI Disease Management Group, and Dr. Ravi, sir, who is a senior and renowned surgical pathologist of Nagpur. Over to you, Avni ma'am.
Thank you, Dr. Renuka, for that very kind introduction. I will start by sharing my slide.
If I may just intervene,
Yeah.
this is to tell all the delegates that questions will be taken up after each talk. So you all can post your questions in the Q&A session. And now the chairpersons, Dr. Mukta ma'am and Ravi sir, with your permission, we can just start with that talk.
I think you can go ahead because we are already behind schedule. Yeah.
Okay.
Sure.
So
Looking forward to listen to you, Avni.
Okay, so I also want to thank Dr. Sancheti. We have been friends since high school, but I am very honored to be here. I wish it was in person, but at least this is one way for interacting. So this is a vast topic. I'm going to talk about the mass lesions of the liver and approach to them by core needle biopsy. What I have done is, rather than going through a long list of things, I have picked a few cases that encountered my service, and hopefully will touch multiple interesting aspects of this topic today. So my practice is a subspecialty practice. So I sign out GI and liver surgical pathology as well as cytopathology. So I know that the title is core biopsies of the liver, but I have included some cytology, especially because, as we were discussing, EUS is becoming very common in Nagpur. And I find that when we make touch preps of our core biopsies, as well as the DiffQuick smears, that is a very good starting point for some of these cases. So with that, we will delve into the topic. And okay, so when we are encountering a biopsy of the liver mass, I think the biggest question is this a benign entity or is this a malignant entity? And if we decide that it is malignant, then the next question becomes, is this primarily arising in the liver or is it a metastasis from a distant primary? This question arises in multiple clinical scenarios, and oftentimes the clinical scenario gives us big clues about what to expect on these biopsies. So a relatively simple situation is a patient with multiple liver masses where we know that there is a known primary somewhere else. On the other hand, the difficulty level is a solitary liver mass, which is not of hepatocellular origin when we look at our slides, but there is no known primary. And at that time, we are expected to provide some answers about where is this coming from. Majority of the liver masses that we encounter in our practice, and I think that's the trend around the world, tend to be a metastasis from somewhere else. And in these situations, they tend to be multiple. But it's important to remember that they can be, in fact, liver abscesses, and they can have very overlapping characteristics on imaging with a metastasis. And the pitfall with abscesses is that sometimes tumors can be necrotic and have a very abscess-like presentation on imaging as well as on our diagnostic material, especially if it is small biopsies. And in that case, it's exceedingly hard to look for these viable tumor cells and come to any kind of definitive conclusions. And talking about EUS, for a number of years, we have relied on percutaneous aspiration of the liver with some kind of image guidance. But now we are seeing a little bit of endoscopic ultrasound guided fine needle aspirations, as well as small core biopsies of the liver parenchyma. It's still fairly rare. I have only seen a couple of cases of the liver. Majority of our cases tend to be pancreatic mass lesions. But I thought I will share one of these examples with you of an ultrasound guided liver core biopsy that was recently performed. So without going into the, I think my slide has moved for me, but not for you. Okay, so there is a little bit of a lag. Okay, we will just work through that because I think there is a lag on my side in terms of what you guys are seeing and what I am seeing. But that's fine. So this is a EUS biopsy of of the liver parenchyma, where you can see that on the top left here and the center, we do have liver tissue that is identifiable. And then we have this big piece of stomach that has come up because this was performed with a transgastric route. So with that introduction, we can move on to this comprehensive list of entities that may present as mass lesions of the liver. And depending on the practice location, amoebic liver abscesses as well as hydatid cysts can be commonly seen, but oftentimes clinical history is very helpful in these situations, and they may not even get a biopsy. And as I said earlier, metastases are fairly common, so that's in a bigger font here. And then among the primary tumors, hepatocellular carcinomas tend to be much more common than cholangiocarcinoma. And then rarely we will encounter mesenchymal neoplasms. And I have one example of that later in our talk. So although hepatic adenomas are relatively rare, I decided to talk about them first and almost kind of get them out of the way before we get into more bread and butter everyday situations. And there are two reasons for that. On core biopsies, I find that this is a rather difficult diagnosis to make. The recommendation is to not biopsy a typical adenoma. So by typical, I mean by a typical clinical presentation and a typical radiographic presentation, but we still find ourselves getting these biopsies. And then it's difficult to differentiate them from well-differentiated hepatocellular carcinomas. Also, the cases are on the rise all over the world because of the increase in the access and distribution of estrogen-based oral contraceptive pills, as well as the obesity epidemic. So traditional view of hepatic adenomas is that they are benign neoplasms of hepatocellular origin. The typical patient has been a woman in the reproductive age group, largely because of its association with estrogen-based oral contraceptive use. But they are also seen in non-contraceptive estrogen increase situations. Obesity is one example, like I said, and also in patients that are exposed to anabolic steroids. The obesity-associated adenomas tend to present in older women and also in men, and it is being considered as an important risk factor in the malignant transformation of these adenomas. So grossly, the tumors tend to be well circumscribed. Majority are less than 10 centimeters, but larger ones can grow fairly large, up to 30 centimeters. They tend to be somewhat lighter in color compared to the surrounding liver, as shown in this photograph here, unless there is hemorrhage, of course. And usually they don't have significant fibrosis or nodularity or satellite nodules that we associate with HCC. And remember that the background liver in these cases tends to be not cirrhotic. Microscopically, they are composed of hepatocytes with no significant cytologic atypia. The tumor shows well circumscribed border, shown here grossly, as well as in this photograph microscopically. The background liver here has an identifiable portal area, and then the hepatic adenoma is on this side. The bottom picture is a slightly higher power picture here, where they're showing a characteristic finding, which is that of an unpaired artery highlighted here by a black arrow. Interlobular bile ducts are not identified in hepatic adenomas, although we can see hepatic ductules, like smaller structures in some of the cases. And the tip that I use to recognize an interlobular bile duct is that they are normally associated with a roughly similar sized arterioles. So we don't see that kind of interlobular bile duct here in the company of this arteriole. Usually the cells are arranged in thin or just mildly thickened cell plates, but sometimes you can have these pseudoacinar type arrangements shown here. And reticulin staining is shown in this panel on the left here. And this staining is similar to that we see in normal liver, background liver, where the hepatocyte plate thickness is only 1 to 2 cell wide. So this is our traditional view of a hepatic adenoma. So more recently, there have been studies looking at demographic data of hepatic adenomas and the incidence of malignant transformation in these lesions, which indicate that metabolic syndrome, which is a combination of insulin resistance, obesity, and hyperlipidemia, is emerging as a risk factor for developing hepatic adenomas, especially in men. So this association is also seen in women over 50 years of age who traditionally rarely developed hepatic adenoma, especially in the absence of history of hormonal contraception use. Larger tumor size have been associated with malignant transformation, and we have known that since before, and newer studies have also held up this observation. Malignant transformation is very rare in adenomas that are less than 5 centimeters in diameter. So that size criteria is in itself very helpful. I've listed beta-catenin activated hepatic adenomas here as being at risk of malignant transformation. So what are those? So recently, there has been a lot of research in the understanding of genetic pathways that govern the pathogenesis of these lesions. And based on those, there have been 4 subtypes of adenomas that are currently described. I'll spend the next few minutes understanding these advances in the diagnosis and then turn back to entities that are more relevant to our day-to-day practice. So this classification of hepatic adenomas was proposed by a group in France. The first 2 categories that are listed here are relatively more common and are also clinically more relevant, like I mentioned, with beta-catenin mutated ones. And they are also characterized by unique morphologic changes that are the reflection of their unique genetic mutations. So hepatic adenomas by themselves usually have a great prognosis. So why do we care so much about them? And that is because of the complications that they can cause. So how does that stratify among the subtypes? So this red arrow here points to the risk association for beta-catenin activated ones that have the greatest risk of malignant transformation. So before we get into the details of that, I want to just quickly go over the 4 types, as I mentioned in the previous slide. So that this is a figure from a 2006 paper from the France group that I mentioned that shows characteristic morphologic features of the 4 adenoma subtypes. The first one here on the top left is the HNF1 alpha mutated subtype. This is characterized by marked fatty accumulation in the neoplastic cells. So you can almost see the delineation between the adenoma here that has a lot of fat and the background liver in the background doesn't have that much. There are no cytologic abnormalities here. You can't see that at this low power, but just take my word for it, as well as no inflammatory infiltrates to be seen. Panel B on the right top shows the beta-catenin mutated adenoma, which is characterized by occasional cytologic atypia shown here by this hyperchromatic nucleus, as well as pseudoacinar arrangements. We typically associate pseudoacinar arrangements with HCC, and they don't normally show up in other types of adenomas. So this is a good feature to look for. Then the adenomas with neither HNF alpha nor beta-catenin mutations, but those that morphologically show inflammatory infiltrates, are put in this category of inflammatory adenomas. And the last one is the group of adenomas where we don't have any specific mutation, neither we have any specific morphologic features. So kind of your hepatic adenoma, not otherwise classifiable. I want to focus on the first 2 because partly because of the time, but the point I want to make is that rather than going into the details of the mutations of the HNF1 alpha mutated hepatic adenoma, I want to mention that the problem with these adenomas lies in fatty acid transport across the hepatocyte cell membrane. And that results in characteristic morphology that is fat accumulation in the hepatocytes. And that we can see on our slide. So that is identifiable. So here are some higher power pictures of a HNF1 alpha mutated hepatic adenoma. At low power, again, it shows that classic well-defined border compared to the background liver. And then the 2 photographs on higher power highlight the steatosis, which is characteristic of this subtype. The reticulin framework is preserved in this type, like I mentioned in the introduction. But the thing to remember with reticulin is sometimes there is loss of reticulin around the hepatocytes with fat. That happens in normal liver. That also happens in this adenoma. So that's a word of caution. I will come back to that when we talk about HCC. And then on bottom right here is a immunohistochemistry for liver fatty acid binding protein. So LFAPP stands for liver fatty acid binding protein. And these adenomas I mentioned have a problem with transporting fatty acids. And that is because this enzyme LFABP gets downregulated. So in the adenoma portion, it is negative by IHC. And always try to include the background liver, which acts as a beautiful positive control, which shows the expression. So this one is morphologically easily recognizable. And when I have this case, I always try to mention the subtype, at least favor it over other, because you are giving the patient a better prognosis, because in these cases, their risk of malignant transformation and bleeding in the hepatic adenoma is very small. On the contrary, is the beta-catenin activated hepatic adenoma. So traditionally, we have looked at hepatic adenomas as the disease of middle-aged women, but it can also occur in men rarely. And it is this beta-catenin mutated subtype that is seen more commonly in males. Morphologically, this subtype is characterized by cytologic abnormalities, so more so than we are known to look for in hepatic adenomas. They can have nuclear pleomorphism and atypia and the pseudoacinar architecture occasionally that I mentioned in the earlier slide. So steatosis and inflammation are not the features for this subtype. So if you see morphologic features in a patient who is male that are indicative of beta-catenin mutated hepatic adenomas, I think it is worth alerting the surgeon that this may be a bad actor, even if you are not completely sure that that's what it is, because the chances of malignant transformation are higher, and they may want to resect this even if it is a small lesion and does not meet the 5 centimeter cutoff. I don't think we need to always do ancillary testing to prove the subtype, but just flagging it as a possibility of more aggressive lesion is still very helpful in patient management. And if you do have the opportunity, then what would work? So here is normal liver in these smaller pictures below, and then beta-catenin activated adenomas in the top pictures above. So as I said, they have the activating mutation in beta-catenin, which results in accumulation of beta-catenin protein inside of the nucleus, which is the characteristic. That's what is going to give you positive staining. Normal livers do have beta-catenin in the cells, but they're usually present in the cell membrane or in the cytoplasm. So this does not act as positive. The nuclear staining is where you know that, okay, there is a problem with the pathway, and now there is an activated mutation. The second thing here is glutamine synthetase, GS, staining, which can be used as a surrogate marker, and I find that a very useful IHC for various different scenarios in the liver. But in this situation, the normal liver glutamine synthetase expression is restricted near the central vein, so in zone 3 or centrilobular hepatocytes. But in these adenomas, it shows strong and diffuse expression of glutamine synthetase, and that zonality of the normal liver is lost. So again, like I said, if you're going to stain these with IHC, then make sure you include the background liver so that you can compare the lesional tissue to the background, and that helps with the interpretation. But the morphology is quite characteristic, and you don't always need the stains. More important than subtyping hepatic adenomas, even now, is to establish it as an adenoma, which is essentially a benign diagnosis, and separating it from a well-differentiated hepatocellular carcinoma. So what helps in that distinction? So you must have noticed that all the photos that I showed you until now were from resection specimens. This difference between hepatic adenoma and HCC is very easy in theory, but putting it in practice is, I find it rather difficult. So a good place to start, even if your specimens are small, is an H&E slide, and I try to look for the interface, if available, between the adenoma or carcinoma tissue and the background liver. So the hepatic adenomas, as we said, we should not have cytologic atypia. The hepatocyte plates should be thin. And in HCC, it's the reverse. The hepatocyte plates are wide. Cytologically, the cells are much larger. They are atypical looking. And I do show reticulin stain here with widened hepatocyte plates. This is an example of a hepatocellular carcinoma. So coming back to the interface here, and I think what I find exceedingly useful is the infiltration of the portal stroma or stroma of a fibrotic band, because most cases are cirrhotic livers, where there is infiltration of these smaller atypical cells or even single cells. Also, the interface of a hepatic adenoma typically has some kind of ductular proliferation, which I'm not seeing here. So favoring this to be an HCC. But this distinction, thankfully, doesn't have to be just based on morphology, and there are other clinical clues that you can use. So I find serum AFP levels in these patients very helpful because those are higher in patients with hepatocellular carcinomas. And lastly, I want to leave you with this notion that don't be afraid of calling something a well-differentiated hepatocellular neoplasm. See comment and not put a hepatic adenoma or hepatocellular carcinoma firmly in your bottom line diagnosis. We have done this. We have sent these cases out to expert liver pathologists, and they have come back with the same diagnosis. What I try to do in my comment is I try to highlight features that would pick one lesion over the other, and then request my clinicians to use their clinical as well as radiologic information. So lastly, the immunostains that we discussed, glutamine synthetase and LFABP, and there are others in a classification of hepatic adenomas into different subtypes. I just want to leave you with this thought that they do not help in classification of hepatic adenomas from a hepatocellular carcinoma. So this is actually a hepatocellular carcinoma here, which is showing a loss of LFABP, and a significant majority of hepatocellular carcinomas actually show strong and diffuse glutamine synthetase expression. So that is not going to help you with this distinction. So is there something in IHC that would help you? So I said start with H&E. If you see this nodule and nodule kind of appearance, then it's strongly suggestive that there is a hepatocellular carcinoma emerging in the background of adenoma. So to be honest with you, you don't need IHC for this particular case, but this is a good demonstration. Glypican-3 is one of the stains that can help you here, because benign liver as well as hepatic adenomas do not express Glypican-3. And the hepatocellular carcinoma, the malignant nodule in this situation, is picking up Glypican-3. Another stain is CD34, where because of the physiology of the way the cancer develops, there is capillarization of these sinusoids, and CD34 is an endothelial marker. So you have very uniform expression of CD34 throughout this. Adenomas tend to be messy. I will not use CD34 to diagnose something as adenoma, because you can see that there is a lot in some areas and there is nothing in some areas. So you have that patchy kind of incomplete staining pattern. But other thing I have seen used that I have not used myself is a proliferation index marked by Ki67. So compared to the background liver, the hepatic adenomas tend to have a similar proliferation rate, and proliferation rate is significantly higher in HCC. But if you're going to do that, make sure that you have some background liver to compare that proliferation rate to. So based on this new information about hepatic adenomas, how is the treatment changing? And the quick answer is not really. The old view, or I should say traditional view of size and gender still holds true. And majority of these get resected if they are greater than 5 centimeters and if they are in women. The classification has affected one group of people, which is older women or even younger women with smaller adenomas. But for some reason, if they're biopsied and if they are shown to have a beta-catenin mutation, then even if they are smaller, they need to come out because their malignant transformation rate is significantly higher, close to 5%. So most surgeons will prefer to take them out. So with that, I'm going to get back into more bread and butter scenarios. So for the next few slides, we can look at hepatocellular carcinoma in greater detail. So HCC is the most common primary liver malignancy. And the important thing which also helps it differentiate from hepatic adenomas is that 80% of these cases happen in cirrhotic livers. And I distinctly remember learning about aflatoxin in second MBBS lectures. But now I think the predominant etiology across the world is viral hepatitis. And the next most impactful risk factor is this massive increase in patients with obesity-related fatty liver disease. So grossly, these tumors are more often solitary, but you can often have multifocal hepatocellular carcinoma. So metastasis comes into differential diagnosis in that situation, as well as a dominant nodule with satellite nodules is also a classic presentation. So I find that the knowledge about the status of the background liver is very helpful. So common wisdom is that metastasis is extremely rare in patients with cirrhosis. So that kind of helps us lean towards HCC even before we have looked at the slides. Radiology is very helpful if you are concerned about cirrhosis, but if you don't have a lot of information, then one relatively widely available clinical test that helps a lot is a platelet count. It's simple, people forget to think about it, but it tells you a lot about the functional status of the liver. And if your patient has a sustained low platelet count over a span of weeks to months, then there is a good chance that they have cirrhosis in their liver. I mean, this is all, of course, if other causes of low platelet count are excluded. And then the other thing that I already mentioned is the higher AFP levels. Again, very helpful. So before we even go to H&E slides, we have all of that information and we can figure out what we are expecting on our slide. So the top left here is panel is a low power view of a biopsy. This one is unfortunately a little fragmented. But normal liver is here in the bottom. We can see a portal area, and then there is some nodularity here with a fibrous band. So this liver did have a background of cirrhosis. And on higher power, we see polygonal cells, which are larger, and they have prominent nucleoli. The architectural arrangement for HCC is typically these trabecular widened hepatocyte plates, significantly thicker than the normal 1 to 2 cell thick plates that we see in normal liver, and then these pseudo-acinar areas. And you can see that they can be of various different diameters, and the larger ones tend to have this like pink frothy material in the middle. So they are pretty good at mimicking glands actually. But moderately differentiated HCCs are kind of relatively straightforward, especially if you find some bile pigment. And that kind of seals the deal that, oh, this is an HCC. One important stain that I want to talk about at this point is reticulin. And reticulin is not an IHC. It is a special stain that stains fibrous tissue. And it is important to know that reticulin is useful once you have established a lesion to be of hepatocellular origin. So if we don't know whether that this is coming from hepatocytes, then it's less useful. But if you're trying to establish that this hepatocellular neoplasm is indeed a hepatocellular carcinoma, then reticulin is your friend. And normal liver shown here has a portal area that has the native fibrous tissue that supports the portal area. But then in the parenchyma here, you can see that only one hepatocyte thick layer, or at the most two, and then you see a reticulin fiber. In HCC, these cell plates are significantly wider, as shown in this photograph here. And you do have some reticulin, but a lot of it is just fragmented. The other scenario is you don't know that that something is of hepatocellular origin. So in that situation, what are the stains that can help you? And majority of our hepatocellular carcinoma, we do not perform IHC on them, but then there are instances where you have a very small piece of tissue, or there is something about the clinical history that prompts you to go that extra mile and prove that this is indeed of hepatocellular origin. And here is a list of stains that I have. Hepar1 is a old marker of liver or hepatocellular differentiation. And it's rather specific. The problem with Hepar1 is that poorly differentiated HCCs may not express it. And that is the situation when you need it, because if it's a well or moderately differentiated, you don't need your stain to tell you that. You just know that by morphology. Some of the other things that I find useful are arginase as well as glypican-3, polyclonal CEA, and TTF1. And TTF1 is typically a lung or a thyroid marker, but in the hepatocytes, TTF1 has a peculiar cytoplasmic staining and not the nuclear staining that we look for in lung cancers. With that, I want to follow up with a couple of variants. So I don't have all the variants of HCC here, but these are some of the cases that I have encountered personally, as well as the importance of this particular steatohepatitic variant is that it's about 20% of the cases that we see. But I think this variant is going to cross our desks more and more often, because this is the one that is associated with patients who have steatohepatitis in their background liver, either from obesity or from alcohol. So the tumor does show the typical features of HCC with wide hepatocyte plates and trabecular kind of architecture, but they have a large fat droplet in their cytoplasm, as well as inflammation and fibrosis that you typically associate with steatohepatitis. Ballooned hepatocytes with these really dark pink Mallory-Dink bodies are also characteristic of this pattern. And the prognosis of this is similar to a conventional hepatocellular carcinoma. So we don't really impact the prognosis or treatment at all, but just it's good to recognize this as a separate variant. And also want to mention the reticulin stain again here, because like I said, the fatty hepatocytes, whether they are benign or neoplastic, can both lose reticulin for different reasons. So if you're trying to use reticulin and your background liver has fatty hepatocytes, you will see loss of hepatocytes even in the benign liver. So that's something to be very careful of, especially on small biopsies. The next one, which is morphologically very similar to the previous one, is a clear cell variant of HCC. And this is a little less common, but this is worth identifying as a specific subtype, because the prognosis for this particular one is actually better than a conventional HCC. So you're telling the patient they have cancer, but at least you're telling them that the prognosis is a little bit better. The cells are large and the cytoplasm appears clear, kind of similar to the steatohepatitic variant, but these cells are full of glycogen. And this smear kind of nicely shows that with this very frothy, bubbly kind of background, because all the cells have burst open and the glycogen is just floating around on the background of the smear. So sometimes the background will give you clues about what to expect with your tumor. The other question with these, and again, coming to the issue of metastases, is that this tumor reminds me of a clear cell carcinoma, typically coming from the kidney. So carefully look at clinical history to avoid that pitfall. But in my experience, the clear cell renal cell carcinomas tend to be very vascular, and they also have a slightly different architectural pattern compared to a typical HCC. So again, you can look for bile formation on IHC, on H&E morphology, sorry. And if you have to resort to an IHC marker, then I recommend using Hepar1 for hepatocellular differentiation, and then Paxate to rule out a renal origin. And a word of caution here against using CD10 is that it can be positive in both renal as well as HCC. So I want to stress, especially if there are any trainees in the audience, that if you are going to use an IHC, I definitely encourage using one positive and one negative marker rather than using just one and then, the possibility of it either not working properly or the tumor has a aberrant expression of it. So always try to use a combination, and also do not diagnose anything just because an IHC stain is positive. You always need to have a good H&E correlate. So there are other variants of HCC like serous carcinomas and fibrolamellar HCC. I don't have examples of them for consideration of time, but I do want to mention them because they are morphologically unique, which makes our life interesting, but they do have different prognoses. So it's important, and also clinical scenarios where they come up, especially fibrolamellar carcinomas come up in younger patients and patients with without a cirrhotic background. So important considerations. This next example of HCC that I included stresses the point that context matters. And it's important to look at the background liver as well and comment on it when possible. So another diff-quick smear here with large nuclei, some pleomorphism, hyperchromatic nuclei, but then I want to bring your attention to these benign hepatocytes that were in the background. And throughout this smear, we kept seeing this like dark brown, black pigment. So the top photos are HCC. H&E has all the features we have discussed: reticulin, nicely lost, wide plates. This here is the background liver, and I'm not sure at this power how much you can appreciate, but it has this brown pigment throughout. And it was a lot more than the normal lipofuscin that you would expect. And this is a 50-year-old gentleman with no specific history, just relatively new to the hospital because has not had issues up until now. But because of this pigment, we decided to do an iron stain on this liver biopsy, and it is just chock full of iron. So eventually we raised the possibility of a genetic issue with iron metabolism. He was worked up, and indeed he was diagnosed with hemochromatosis. So again, I'm going to address the students and the trainees in the audience that if you have made one diagnosis, don't pat yourself on the back. Make sure you have looked at the whole thing and provided explanation of the entire thing. So talking about pigment, this time it's not in the background and it is inside of the tumor cells. So we can see some pigment here in the cytoplasm of some of these tumor cells. And this can be particularly difficult to differentiate because hepatocytes can themselves have the wear and tear pigment. So we'll have to sit here, carefully look at this smear, just take my word for it that there is pigment in these large neoplastic cells. So diagnosis-wise, most of the times it is not difficult to make a correct interpretation of metastatic melanoma. This is a cell block. You can again see pigment, and none of these cells look good for cells of hepatocellular origin. And I bring this up here because in terms of metastasis, melanoma is definitely in the differential diagnosis for a poorly differentiated hepatocellular carcinoma. And it is of particular importance because there are instances, not rarely, where melanoma presents as an occult primary. People are unaware that they have a melanoma and then it shows up in the liver. And I think I'm biased because of my practice setting, given how much melanoma we see. But I think it's still important to remember that anywhere you are demographics wise. So the classic features are that cells are somewhat discohesive, and I find it always better presented on a smear rather than on a biopsy where the architecture is intact. The cells are large. You can, even on diff-quick, you can see these nuclear inclusions. NC ratio of these cells is, some of these cells is fairly low. Luckily, we had a good core biopsy for this case, which was full of pigmented cells that were atypical, obviously malignant looking. So this was not a diagnostic dilemma. But as we all know, melanoma is a great mimicker and it doesn't have to declare itself on H&E that easily. So if you ever find yourself in that situation and are looking for some immunohistochemical help, then here is your list of things to include. So we'll keep up with the theme of metastasis here and look at the cells. They are always important, but sometimes the clues are in the background. So our next metastasis is not from the colon, because that will not be interesting. So instead, we'll look at this one here. In the smear, we see matrix material. There are some hepatocytes here. There's tumor here. Again, matrix is very closely associated with the tumor cells. And then we have our core biopsy here, which there is a little bit of normal liver. Then all these tumor cells are kind of thinned out because there is a lot of this extracellular deposit throughout this biopsy. So now I'm going to tell you that this patient has a history of breast carcinoma. So we're already thinking metastasis. The reason I included this particular case is to make a point that sometimes we find ourselves thinking, oh, if I had a breast marker, I would throw it on there and it'll light up and it'll be a breast metastasis. But GATA3, which is a breast marker, was completely negative in this biopsy. So that is unhelpful. So IHC is not going to help you every single time. So the take-home point is that this is a metaplastic breast carcinoma. Metaplastic breast carcinomas make a lot of this extracellular matrix, which is a classic morphology. If you are thinking about it and if you know the history of the patient, it becomes very easy. Oftentimes, these tumors are negative for the classic IHC markers. So in this case, we had the prior history, we pulled the prior breast case, compared it, the tumor looked the same. So diagnosis is metaplastic breast carcinoma, metastasis to the liver. So we looked at a few examples of metastasis, and we operate with that notion that multifocal tumors in a non-cirrhotic liver especially are going to be metastasis. But there is never a dull moment in a pathologist's life, and I am sure I don't need to convince you of that statement. So here is the next patient. This patient had a history of breast carcinoma, low grade, treated with lumpectomy 2 years ago, and now she presents with multiple liver masses. Presumptive clinical diagnosis is metastatic breast carcinoma. They performed a biopsy because they wanted to look at the hormone receptor status for her disease, for her metastatic disease, so they can decide further treatment. So I get the biopsy. And low power, you're not really seeing any typical breast carcinoma picture. There is no gland formation. You're seeing this kind of loose, spindly cells in a kind of hyalinized fibrotic background. They're quite pleomorphic and frankly malignant looking in some situations, but they're just fewer and not gland forming. So I like to bring your attention to this higher power image here, because there is some structures in these cells that are the clue for what this lesion is. So these are small intracellular lumina that are being formed, and one of them actually has a red cell inside of it. So morphology, careful morphology tells you that this is an epithelioid hemangioendothelioma. And this is a rare cancer, but this seems to follow me around because the incidence versus the cases I have seen just does not make any sense. But the reason I include it here is it is not a metastasis. It can arise primarily as a mesenchymal tumor in the liver, and oftentimes these are multifocal. So if the patient does not get a biopsy, and we go with a presumptive diagnosis of metastasis, that may be wrong. Fortunately, the situation arises fairly rarely. And the other caution with these tumors is that sometimes these cells can be positive for keratins, which are markers of carcinoma. So that's another pitfall to avoid. So poorly differentiated adenocarcinoma could come in the differential diagnosis if you decide to rely on your keratin staining. So that brings me to this age-old question of poorly differentiated carcinoma or any adenocarcinoma for that matter in the liver, whether it is a metastasis or it's a cholangiocarcinoma. So here is a photograph, actually 4 photographs. And my question to you guys is, which one is the primary? So the lower right corner is obviously a metastasis because it's from the colon and it's typical morphology and we know how to identify colon cancer. One of my teachers describes colon cancer as tall, dark, and necrotic because of this dirty necrosis instead of calling it tall, dark, and handsome. But jokes apart, this one we can identify. What about these 3? So with the other sites of adenocarcinoma, we are not as lucky as colon, particularly the upper GI and pancreatic adenocarcinomas. If you have a patient with a lung mass, then things become easy. But if you don't have a mass lesion somewhere, and if you have a liver mass, particularly if it is solitary, then definitely consider an intrahepatic cholangiocarcinoma. They are rare, but they are not that rare. If they have this kind of fibrotic, densely fibrotic background, then consider yourself lucky because that's one of the hallmarks of cholangiocarcinoma, but you don't always see that, especially if you're trying to diagnose it on a biopsy. You may just get an area that is more hypercellular and not quite fibrotic. So what do you do in that situation? And often I'll just leave you with this fact, actually, that oftentimes it's not possible on morphology alone to differentiate these cholangiocarcinomas from adenocarcinomas of other sites, particularly upper GI and pancreas. So one of these photos is a pancreatic adenocarcinomas, one of these photos is a gastric primary, and one is cholangiocarcinoma. And I'll just tell you that this one with the fibrotic background is indeed cholangiocarcinoma. So we often diagnose these cases as moderately differentiated adenocarcinoma C comment. And in the comment, we will use the radiographic information as well as clinical information. And based on that, give our pathologic diagnosis. Because there is no good IHC marker that will tell you that this is a cholangiocarcinoma. So it's not a matter of availability, it just doesn't exist yet. So how are we doing with time? I think we are doing okay, but I'll speed up. So with that, I'll change gears and discuss an example of a non-tumor mass lesion that can happen in the liver, mainly in association with the bile duct system and also in the pancreas. So this biopsy or a touch prep is from a 65-year-old male with features of obstructive jaundice and bile duct strictures were seen, but he had these mass lesions for 2 years. So clinically suspected of cholangiocarcinoma, but something doesn't really fit because cholangiocarcinomas tend to be aggressive and something would have happened to him in the past 2 years. So we have these touch preps, they have these, nice little plump benign hepatocytes, nothing much, a few little maybe inflammatory cells. So the next day we look at our core biopsies and they are telling a different story. So we have this significant amount of fibrosis in the biopsies and these dense areas of inflammation. So those are our keywords, fibrosis and inflammation. You look at it at higher power, and this dense inflammation is quite rich in plasma cells. Here's a big artery, and it's centered on the vein here, kind of cuffing it and compromising the lumen of the vein. So this is an IgG4 associated sclerosing cholangitis. And I did not know about this entity in MBBS. This is relatively new. This tends to be in males over 50. And clinical or lab correlate is that these people have higher serum IgG4 levels. They can have manifestations in other organs. Pancreas is a common one and present with this obstructive jaundice type picture. They can have elevated CA 19-9, which we associate with pancreatic or biliary carcinomas. So this inflammation fibrosis makes a mass lesion. You have elevated CA19-9 and you are going to make a clinical conclusion that this patient has a malignancy. But the reason it is so important to diagnose this disease is that it has excellent prognosis. Majority of these patients will respond beautifully to steroid treatments, and there is no increased risk of cholangiocarcinoma in these patients. So the characteristic morphologic features that we looked at on the previous slide, these dense lymphoplasmacytic inflammation areas, and they have storiform fibrosis, which looks like kind of cartwheel pattern of fibrosis. If you are in the pancreas, the inflammation tends to be duct-centric. If you are in the liver and the biliary side of things, the inflammation tends to be centered on the peribiliary glands. And they also have obliterative phlebitis, where the lumen of the vein gets obliterated by the presence of this inflammation and fibrosis. And as the name suggests, you can do immunohistochemistry for IgG4, which is shown here at low power and high power. And the biopsy criteria currently is that in a high power 40x power field, you need to have at least 10 IgG4 positive plasma cells. So there is about 18 in this photograph. So
sorry to intervene, if you can wind up in the next few slides.
Yep. So I have last 2 slides, and this is just a fun scenario, which is the reverse of what our title is. In this situation, there is a malignancy which just refused to form a mass. This biopsy came to me with a clinical history of significantly elevated liver enzymes, mainly AST and ALT. Patient has a history of breast cancer, but there is no clinical or radiologic suspicion for metastasis. Working diagnosis was drug-induced liver injury because of side effects from chemotherapy. I look at the biopsy, I'm expecting portal or lobular hepatitis, maybe some cholestasis, but instead I have these portal areas that look busy, but they don't quite look blue, like they don't have the small inflammatory cells that you would expect. Instead, there are these atypical large malignant cells. And this patient had a history of lobular carcinoma of the breast. So they are nice and discohesive. And this pattern of malignant kind of portal infiltrate repeated throughout this biopsy. Every single portal tract was involved, but there was no mass formation. So I just wanted to leave you with this one case that unfortunately, this is not a good prognosis for the patient, but regardless, interesting case for us that this is not a mass forming entity, but indeed still a metastasis. So with that, I would stop here. Like I said in my introduction, this is a vast topic and we could keep going, but I'll leave you with some of these conclusions and I'm happy to answer questions. And thank you very much for your time and attention. And I will also stop sharing my screen at this point. Are there any questions, or are we going to wait until the end?
Thank you, Avani. That was a great talk. You covered most of the difficult areas in the liver biopsy arena. Are there any questions for Avani?
Yeah, if I may ask, like I don't know, Mukta ma'am may be able to comment, but we don't see hepatocellular adenomas so often. But I think you have really elaborated it very well with all the new types of the mutation and all. I mean, if Mukta ma'am can tell if you all are seeing any of those hepatocellular adenomas specifically.
Yes, we do see. In fact, I was going to ask only this, similar question. Maybe the reason that we don't see very many of them is because, Avani, what is the policy that your center practices as far as the biopsy is concerned, with both the HCCs and the adenomas?
And you can stop sharing your screen so that.
Yeah, and I'm trying to find that, where to stop sharing. Is my Zoom is not showing me that.
The upper panel you may be able to see.
Can somebody else?
Seen at the top of the screen.
Just take your cursor to the top. It will come down. The panel will come down.
Yeah. Let me let me try answering the question.
Yeah,
So
okay.
the societies of all the societies, the European as well as American Gastroenterology Society does not recommend biopsying a typical adenoma, which you can identify by radiology as an adenoma. But that is not what we see in practice. And I think they are not common cases, but I would say I would get an adenoma once a month. And I think I may be biased probably because the liver practice at Duke is a large medical liver practice as well as transplant. So there's a number of liver transplants. So I think we attract this group of complicated patients because of the nature of the hepatology practice there. And I think because of that, I'm biased and I see more. But typical ones should not get a biopsy.
Yeah, and is that also applicable to hepatocellular carcinomas? Because I mean, I was reading a radiology paper and I was quite surprised that they actually recommend no biopsy for lesions which are more than 1 centimeter, which is quite a low threshold. So what's your practice? Like we also don't get all our HCCs or adenomas. Adenomas are biopsied. Somehow they are biopsied because maybe they are rare.
Yeah.
But the HCCs not all go for a biopsy. So, but 1 centimeter is certainly not our cutoff.
Yeah, so I think our situation ends up being kind of practitioner dependent. Different people end up doing it differently, but a lot of the small hepatocellular carcinomas don't get biopsied because if they can ablate them either by embolizing them. We often get cases where even for larger lesions, they are directly ablated. They do not biopsy them if the radiologic evidence is very strong and they get classified as HCCs by radiology. And then we will directly get a partial hepatectomy where we see like 5% of viable tumor, majority of it is dead because of the embolization. And then in certain scenarios, if the tumor is large and majority of these patients have cirrhosis, so if they're going to transplant them, which happens rarely, but still happens, then we get the whole liver as the explant, and then see these HCCs that have been very successfully treated actually by embolization.
Yeah. Yes. Thank you.
Have I stopped sharing my screen?
Yes.
Okay.
Yes, yeah.
Because I was talking at the same time, so I got confused. Yeah.
Dr. Ravi, do you want to make any comments?
It was indeed a very wonderful presentation, and we in practice end up seeing mostly metastasis.
Yes.
Mostly metastasis.
Yes.
We end up and hardly any adenomas. Most of them are metastasis, and of course we are seeing non-neoplastic quite a bit.
Yeah.
So anyway, It was a very beautiful, and a special moment for me because I was also your father's student.
Thank you. I never thought when I was a teenager, especially, that I would become a pathologist, but here I am.
Thank you.
Yeah. Thank you, Avani. Thanks for joining us.
Sure.
And if you wish, you can stay online now. Yeah.
Thank you, Avni. Thank you, Avni ma'am, for extremely engaging presentation. Please accept our sincere appreciation for the time and efforts you took to share your knowledge and experiences with her. Thank you, Ravi sir and Mukta ma'am. Now, after the commanding opening of this session, we will move to the next talk of the session by Dr. Amit Agarwal, sir, who is a renowned consultant gastroenterologist. He is a renowned consultant gastroenterologist, hepatologist, and therapeutic endoscopist at Disha Clinics and Hospital, Nagpur. He has special interest in pancreatobiliary interventions, EUS, and ERCP. He is a member of various national bodies with many publications and papers at national and international level. I request Dr. Prashant Bhandarkar, sir, who is a senior and renowned gastroenterologist in Nagpur, to chair this session. Over to you, Agarwal sir.
Okay. Visible?
Yes, sir.
Yeah, your screen is visible.
Okay. Good evening, everybody. Thanks to Dr. Prachi and VAPM for this opportunity. Today, I've been given the task to speak on endoscopic ultrasound guided FNA, the techniques and the applications. So what is EUS? Basically, it's a combination of endoscope along with high frequency ultrasound. So normally we have endoscope, which visualizes the internal mucosa of the GI tract. And when it is combined with high frequency ultrasound, it becomes an endoscopic ultrasound. So the advantage of EUS is that it gives proper imaging of the GI tract wall, as well as the proper evaluation of the structures which are in close proximity to the GI tract can be properly evaluated. The problem with normal ultrasound is that when we do ultrasound, a lot of bowel gases are there, which obscures the visualization of the deeper structures like pancreas. And when you do something like CT guided FNA, the things are difficult because we need to go through the vital organs to acquire the tissue for the analysis. So we have two types of EUS scopes, one being the radial scope. This is the classical radial scope, which gives us the perpendicular visualization, 360-degree visualization of the GI tract vicinity. It is same as that of CT scan. And this one is the radial scope, this linear scope, which has got a transducer at its tip along with a working channel through which the needle can be inserted and FNA can be done. The visualization is not 360 degrees, it is just somewhere around 120, 130 degrees. And the advantage of linear scope is that it helps in, it has got therapeutic implications as well as it helps in acquiring the FNAs. Since these equipments are extremely costly, most of the centers have linear scopes only, and radial scopes are there only in teaching institutes. So as you can see here, this is the linear scope with a transducer at its tip, and the camera is there, and the needle is there, and needle comes out to the working channel. It pierces the gastric or any luminal wall, and it takes biopsies, FNAs from the surrounding structures. We have different types of needles. The most commonly used needles are the 22 gauge needles. In majority of cases, almost 90% of the cases for FNA and FMB, we use 22 gauge needles. These are optimal size and gets proper tissue. Equation is good. 19 gauge needles are a little wider. These are mostly useful for therapeutic purposes like performing cystogastrostomies, performing some other types of therapeutic interventions. And 25 gauge needles are a little smaller or thinner, and these are specifically used when the lesions are vascular, or when there is high risk of bleed, and or when there is a need to go through some vessels like an artery or a vein. So in majority of cases, we use 22 gauge needles. Now, last decade has witnessed a tremendous revolution in the field of needles. These are the classical FNA needles. We used to have a bevel end at the tip. The yield with these needles were very less. So subsequently, a lot of FNB needles came. So these needles are wider in diameter, as well as these got multiple bevel ends. This is the first generation core needle, and this is pro-core needle with reverse beveling, which was modified subsequently for better yield to forward beveling. And so these are the needles from various companies, and almost all of them have similar efficacies. So there is a transition from FNA needles to FMB needles, and that has made a tremendous change in the acquiring tissue, and the positivity has increased. So what all EUS can do? It can do FNA from all the structures which are in close proximity to the stomach or even rectum also, esophageal, rectum or stomach. So what it can do, it can take biopsies from the liver, from the biliary structures, pancreas. It can FNA lesions from the spleen. It can do mediastinal FNA from the mediastinal nodes, as well as it can do FNA from the ascites and peritoneal mets also. So what are the indications of EUS FNA? In majority of cases, the patients are referred to us for a deep-seated pancreatic lesion, be it a solid or a cystic. In patients who have biliary structures, which are difficult to sample with CT or ultrasound, These lesions can be FNA'd with the help of Hemoscopes. Liver lesions, or as very nicely discussed by Dr. Avni in the first lecture. Metastatic hepatocellular most of the lesions are amenable with percutaneous nearby ultrasound or CT. So these lesions rarely come to us for FNAs. Then esophageal and gastric wall thickening can be evaluated with the help of EUS, lymph nodal staging, subepithelial gastrointestinal tumors. So most of these lesions have smooth mucosa. So FNA is very much helpful. EUS is very much helpful to acquire tissues from these lesions. Assessment of mediastinal and abdominal lymph nodes, which are deep-seated, very difficult. Most of them require surgery. So EUS is very helpful in such conditions. Again, left adrenal gland lesions, especially if there is suspicion of tuberculosis or histoplasmosis, splenic masses, peritoneal carcinomatosis, and when there is perivascular tumors, extension of thrombosis. When we talk about EUS, Fna and Fmb, so the method remains same. The only difference is in the needle. So we all know that EUS Fna gives us tissue which has doesn't retain the stroma, and the architecture is completely distorted. So sometimes diagnosis is quite difficult with EUS FNAs. Fnb needles, with the availability of core biopsy needles, the things has become more better. The tissue acquired is good, the cellular architecture is preserved, and it helps in establishing a definitive diagnosis, as well as performing various ISC and other molecular profiling, which are helpful for oncological therapies. So what are the indications of FNB? When first it being FNA is inconclusive. Now, since last few years, almost all the centers have shifted from FNA to FNB. The reason being that FNA, the yield is very low, and with the availability of FNB needles, most of the centers have shifted to FNB. When the tissue architecture is extremely important, like in lymphoma and in autoimmune pancreatitis, so FNB is extremely helpful, especially also in such conditions when immunohistochemistry is required. To perform tissue profiling or cell cultures for targeted therapies, for malignancy especially, and in centers where Rose facility is not available, which I will discuss in my next slides. So what you can see here are the four hypoechoic masses in the pancreatic head. So all of them look similar. All are hypoechoic and situated in the head of pancreas. But when we did FMB, the first one turned out to be NET, the second one turned out to be adenocarcinoma, third one lymphoma, and fourth one TB. So the importance of why I'm showing this slide is that the trick lies not in looking at the lesion. The trick lies more in the acquiring proper tissue and analysis of the tissue to come to a particular diagnosis. So ES helps in identifying the lesion. The most important part of EUS FNS is to acquire proper tissue. The tissue should be adequate enough to for examination and coming to a particular diagnosis. So what are the EUS FNS steps? I will do it quickly, which will not be important in this forum. So EUS needles are quite large needles, and it has got one handle also. So it fixes up on the scope, and the needle is inserted. The needle contains three layers, one internal being the stellate, outer being the sheath, and in between the two lies the needle. So it is fixed up on the therapeutic channel, and it has got two locks, one for the sheath and one for the needle. And depending on the size, the distance of the lesion, lesion from the transducer, the distance is marked and a jab is made and the tissue is acquired. So I will show you this video where you can see a large hypoechoic mass in the head of the pancreas with dilated CVD. You can see here that the needle is moving to and fro inside the lesion, and the assistant is gradually withdrawing the stellate from the needle. So this is capillary action, and the needle stellate is gradually withdrawn as the to and fro movements of the needle is made. And the attempt is made to identify to take the biopsies from almost all corners of the lesion. The reason is being that the tumors are not uniform always, and taking biopsies from the necrotic areas may miss the tissues, proper tissue tumors. So after taking out the needle, the stellate, the needle is pushed by 1 or 2 centimeters, and the stellate is reinserted on the slides. So it's a long needle. It takes some time to reinsert the stellate inside the needle, and what you can see is that gradually as the tissue comes out, and it is taken out on the slide. So the most important is to have tissue on the slides and analyze the tissue properly so as to identify the macroscopically visible complexes which are white in color. So most of the these tissues are hemorrhagic, so it's very important to separate the whitish colored lesions from the blood clots. You can see some whitish lesions. The lesions are picked up with the help of the needle, and this tissue is then put in the formalin containing water. The residual tissue which is lying on the slides is the thick and the thin smears are prepared, and these are now put on the alcohol containing jars, and a few slides are air dried and sent for examination. So we know that air dried samples gives us proper cytoplasmic evaluation, and alcohol free gives us proper analysis of the nuclear details. Now, there are various techniques or methods in EUS FNA. So this may not be important in this forum, but just to mention few lines about it. One being the suction. Now suction has been withdrawn. In majority of cases when suction is applied, the tissue is mostly hemorrhagic. So suction is not often used, except when the tumor is very hard, we are getting dry taps repeatedly, then suction is used. The most important being the capillary action, which I showed in that video, when the stellate was gradually being withdrawn as the to and fro movements of the needle was being done. So it helps in taking out more and more samples inside the needle, and it gives us proper sample for analysis. Analysis is finding technique. So as showed you that in that video also, we try to take the samples from all the corners of the lesion, because the lesion is not uniform. There are areas of necrosis in the lesions, and if you take biopsies from the necrotic areas, the sample may come negative for malignancy. So fanning technique is equally important. So if you look at the yield of Fna and Fmb, you will find that the yield is somewhere between range of 70% to 90%. This Fna has had a higher yield because those were associated with rows. So as the Fnb needle came to the market, the yield increased to almost 96%, but never has gone up to 100%. So a lot of patients, we find it difficult to come to a diagnosis. The reason being that we are not able to take out the proper tissue, and the sample comes false negative. So what are the causes of false negative Fna? The most common cause is that when we place either placement or targeting of the lesion is not adequate. If the biopsy is taken from the lesion is not from the tumor tissue, the Fna may come negative. Second important being when the patient is having associated chronic pancreatitis. This is a very difficult scenario for us, because presence of chronic pancreatitis masks the tumor, and it becomes very difficult to distinguish the chronic pancreatic mass, the pseudotumor, from the mass, from the tumor mass. And presence of chronic pancreatitis, it decreases the yield by almost 20%. So it's a very difficult scenario. Almost all of us struggles when the patient comes to us for the Fna, and it becomes very difficult sometimes. Even after repeating the Fna for 2 to 3 times, the tissue comes negative, and only in follow-up cases we come to know what is exactly happening to the patients. So what should we do to these patients to increase the yield? The first few studies have shown that there is an increased yield when the initial Fna is negative, and when we do re-Fna, the yield is 30 to 60%. Now, when we start doing EUS FNAs, almost in 25 to 30 initial cases, the nights are sleepless. The reason being that getting a negative result after doing FNB is almost like worrisome for us. It is worrisome psychologically for the treating endocrinologist, as well as financially for the patient. The limitation of doing repeat FNA is being the repeat anesthesia is required, and the cost of the procedure. It's very important to mention this thing about the cost of the procedure being so high that is beyond reach for a lot of patients. So if you look at the cost total involved in doing FNA in patients, is that the cost of the equipment is somewhere around 1 crore. The cost of the needle is 30,000 that can be used in 2 to 3 procedures. Number of FNAs, average number of FNAs in good centers is 10 to 15. It may be high in high volume centers, but average number of FNAs somewhere between 10 to 15. Then cost of AMC, CMC, maintenance cost, anesthesia. So the cost total, it goes somewhere around 30 to 40,000 rupees for a patient. And if we do repeat FNA, patient has to spend at least 15,000 rupees. So getting a negative FNA report is something like we don't want. So almost all the measures are taken to increase the yield of the US FNAC. So few studies have evaluated the role of repeat FNAC, and the other methods includes ROSE, that is rapid on-site evaluation, MOSE, that is macroscopic on-site evaluation, contrast, enhanced EUS, and elastomer. So we will discuss each one of them one by one. So what is ROSE? ROSE is to have a histopathologist in the endoscopy room. So as soon as we take out the sample, the pathologist sitting with the microscope in the endoscopy room itself, he analyzes the sample and see whether the sample is adequate or not. If the sample is inadequate, we do repeat passes, and people have done up to 7 to 8 passes. So what I showed in the video is that was one pass, and if the tissue comes negative, then we do repeated passes till the tissue is adequate for diagnosis. So advantage is that it improves the diagnostic yield by 10 to 30%. It prevents the inadequate specimen for pathologic analysis, thereby reduces the repetition of the procedure. It reduces the number of passes, and it also decreases the duration of diagnosis. The most important limitation is the unavailability. So most of the centers can't have in-house or in-lab histopathologist, and that becomes important limitation, and certainly cost. So these are the important limitations, and only few centers can have in-lab histopathologists whenever they are doing EUS. So this is the study which came in 2011. We showed the importance of rows, and it showed that when there was on-site pathologist, the sensitivity jumped from 78 to 96%, and p-value was significant. And also the overall accuracy also increased up to 97%. So when this study came, almost all the treating endosonologists and histopathologists have very tough time. Endosonologists started convincing their pathologists to sit inside the lab when they are doing FNAs, and it was a very tough time. So the things went on, and with the availability of Fnb needles, when it was compared with FNA, it was found that with the help of Fnb needles, the diagnosis is substantially better sample amount, ease of reporting, and shorter sampling and pathology. So Fnb needles were found to have decreased sampling time, and pathology sampling time was also decreased. And also when the yield was compared, it was found that the Fnb needles has higher accuracy, higher sensitivity, and better positive and negative predictive value. So the study concluded that, which was published last year only, that Fnb needles are better as compared to Fna needles. So the idea came to mind that why not to compare EUS Fnb needle with EUS Fna plus rows, that is to compare Fnb needles with Fna and along with the rows. So it was again just published this year only. It was found that there was significant difference. Both the diagnostic accuracy and sensitivity was almost same. There was no difference even if the pathologist was there inside the room. And the advantage was that the number of needle passes and the procedure time was significantly different. So it was found that EUS Fnb alone was at par with the EUS Fna plus rows. So if you are doing EUS Fnb, you are using biopsy needles. Even if you don't have in-house pathologist, the results are almost same. Now, there is a very evolving concept of macroscopic on-site evaluation, that is MOSE, where the macroscopically visible complexes are seen. So you can see in the slide, there's a hemorrhagic clots. This is the tissue, whitish tissue, and this is the blood, which is lying after doing FNA. So these macroscopically visible complexes are separated from the clots and the blood, and these are then put in the formalin bottle. It was found that when the macroscopically visible complex length was more than 4 mm, the accurately estimated the presence of histologic core showed significantly higher sensitivity in terms of histologic, cytologic, and overall evaluations. Also, FNA can be terminated once the MVC length of more than 4 mm was obtained. So if the length of the macroscopically visible complex is more than 4 mm, the yield is very high. So it was found that the sensitivity, specificity, all were extremely high, 94%. Only 6% has a negative cytology report. So when the comparison was made between complexes less than 4 mm versus complexes more than 4 mm, it was found that the per-plus analysis, cytology, and overall accuracy was extremely high. So whenever we are doing FNA, we try to have a complex length of more than 4 mm. And if it is more than 4 mm or some whitish tissue is visible, we are happy that probably the lesion with this tissue will come positive for the malignancy. So this study again published this year only. So it evaluated the efficacy of MOSE. So it showed that the overall accuracy MOSE was 97%, sensitivity was 96%, specificity was 98%, and positivity and negativity was almost 100%. So it has been now said that in the presence of MOSE, with the using MOSE, if we may replace even those. So what you can see here, the bloody specimen with a lot of whitish tissue inside the bloody specimen. So these are the macroscopically visible complexes. And when we see such complexes after doing FNA, we are extremely happy. And if we see these complexes, we don't take further passes. We stop the procedure there and we send these samples for analysis. Now, when the people were struggling to have proper diagnosis with Fna needles, an idea came to the mind of a lot of people. Why not to train the endocrinologist in evaluation of the sample? So this was a very important study when 4 out of 10 diagnostic cytological features of carcinoma were focused, and these things were trained to the endocrinologist, like nuclear enlargement, anisocytosis, nuclear crowding, and nuclear membrane irregularity. So the authors concluded that they were able to diagnose the adequacy of sample to some extent. Subsequently, few studies came which were controversial. It was found that they were not optimal results when the endocrinologists were trained. So the idea took a backseat with the availability of those large core needles, and with the availability of core needles, even if the endocrinologist is not trained, the results are fantastic. So this idea took a backseat, and now people are not focusing on this. One should always know what are the complications of EUS Fna. So EUS Fna is not completely safe. Patient may develop acute pancreatitis, especially if we pass through the pancreatic duct. Patient may develop bleeding because the lesion is extremely vascular, or if there are a lot of collaterals, especially in the patients who have chronic pancreatitis. Patient may develop abdominal pain, which will be mild post-procedure because of increased gaseous distension or because of pancreatitis. Sometimes patient may develop perforation, which is quite rare because the needles are thin and usually perforations are not seen. Pneumothorax can occur when the lesion, we take mediastinal lymph nodal biopsies, and needle tract staining is again another problem which can be seen with EUS Fna. But when we take Fna, we always see that if the patient is planned for surgery, the same area is taken out during surgery also. Now to deal with the problem of negative Fna, the contrast EUS came into picture. So advantage of contrast EUS is that the focal pancreatic lesions can be studied, and it showed that characterization of ductal adenocarcinoma can be done properly, which is classically hypoenhancing. Also, differential diagnosis between pseudocyst and cystic tumors can be made. Also, differentiation of vascular and avascular components of the lesion can be distinguished, which has an importance in the fact that early detection of necrosis in acute pancreatitis, and also to differentiate between pseudocyst and neoplasia. So if we can differentiate between vascular and avascular lesion, we can distinguish whether the lesion is solid because of malignancy or because of chronic pancreatic pseudotumors. Then defining the dimensions and margins of the lesion, which is important for operability. Then diagnosis in cases that indeterminate on CT. Sometimes few lesions not be determined on CT. So doing contrast EUS sometimes helps in such scenario. So this is a classical ductal adenocarcinoma, which can be seen that it is hypoenhancing after injecting contrast. And this is a classical neuroendocrine tumor, which is extremely vascular tumor. Because of increased vascularity, it shows classical hyperenhancement. So contrast EUS definitely helps in some selected scenarios when we have limitation with the standard EUS. Another thing in EUS is elastography. So this elastography, shear wave elastography, helps in a particular scenario when in the EUS Fna is negative or inconclusive. So EUS elastography can show the hardest area. So the hardest area can be targeted, which shows that probably the tumor mass is there only, and it helps in increasing yield of the sample. So the color patterns, different color patterns. The green indicates soft normal tissue. Green, yellow, red indicates fibrosis, and the lesion, if it is blue, that indicates that the patient is having polypancreatic adenocarcinoma. The classic pancreatic adenocarcinoma, here you can see the lesion is completely blue. That indicates is adenocarcinoma, and here the lesion is green. That is a classical pancreatic teratoma. So this is extremely helpful in scenarios like chronic pancreatitis with pancreatic adenocarcinoma. When the blue lesion, if on elastography it is showing blue color, that indicates possibly there is underlying malignancy. So this is a classical elastographic picture of pancreatic adenocarcinoma, which is showing enhanced hypoenhancement after injecting contrast. And this is again a malignant lymph node, which is showing blue pattern, suggesting that it is a malignant. EUS and liver has been nicely discussed by Dr. Avni in the previous lecture. The technique remains same. There is no difference in the technique in acquiring tissue. Only thing, because the liver is a large organ, most of the lesions are amenable with CT or ultrasound. So rarely we need to do FNA in such lesions, especially in scenarios when the patient is having gross ascites and the coagulopathy is there, when in that case, EUS is sometimes helpful. Most of the EUS the role of EUS for liver comes for therapeutic purpose, like drainage of the biliary tract, injection of the coil or glue for the large gastric varices. About lymph node, it's very important to know that sometimes we get lymph nodes which are solid. We don't find proper mass to FNA, especially patients who have adenocarcinoma. And we see a lot of lymph nodes there. So we do FNA from the lymph nodes. Always remember, FNA is done first from the lymph node, then from the mass, because if we do FNA from the mass first, and if we do FNA from the lymph node, probably we may metastasize the tumor tissue to the lymph nodes. So it's very important to know that the lymph node is classically round. It is more than 1 centimeter and it's hypoechoic. And all these factors are there, we label that the patient is probably having malignant lymph node. So this is classical benign lymph node when the lesion, the lymph node is irregular or oval in shape. So it's very important to identify which lymph node you should sample. So patients who have malignant appearing lymph node, only those lymph nodes are sampled. About just a passing mark on mediastinal lymph nodes. Now we know that EBUS is also there and EUS is also there. For mediastinal lymph nodes, these are the lymph nodes which can be sampled by both EBUS as well as EUS. And these are the lymph nodes which can be evaluated only by EUS. And the lymph nodes which are located in the periphery, this can be evaluated by EBUS because they can go into the right and the left bronchus and can sample those lymph nodes. The importance lies in the fact that there are two stations which are very important for us, the aortopulmonary window and the subcarinal area. These are two areas where we specifically look for lymph nodes, and if the lymph node is found, we do FNA from these lymph nodes. It's a very simple procedure and it's very assuming less complications, and it has changed the evaluation and management of mediastinal lymph nodes to a large extent. Last slide about the subepithelial lesions. You can see the lesions have smooth overlying mucosa. If you take biopsies from the lesions, the biopsies will come to be negative. So EUS helps in identifying the lesions, which layer it is arising from, and also it can help in taking biopsies from these lesions. So you can see a classical lesion which is arising from the muscularis propria, and it turned out to be GIST. So EUS tells about the 5 layers of the GI tract. The first 2 layers are the mucosa, third layer is the submucosa, fourth layer is the muscularis propria, and the fifth is the cilia. Why it is important? It's important because the layer of origin is very important. If the lesion is arising from the second or fourth layer, probably the patient is having leiomyoma or GIST, and majority of the lesions arises from the submucosa, that is third layer. So identification of the area or of the layer from where the tumor is arising helps in coming to a particular diagnosis, even without doing FNA. Also, lesion echogenicity is very important. Majority of the lesions are hypoechoic or isoechoic. Some lesions like lipoma are hyperechoic, and if it's there, then one can again identify the lesions without doing FNA. This is about our experience. We installed EUS scope 14 months back only, did around 135 procedures, and in 55 FNABs, the positivity rate was 75%. So we could do, the majority of them had pancreatic adenocarcinoma. Some of the interesting cases were like autoimmune pancreatitis and paraganglioma, which was done by my colleague, and GIST were seen in 3, and lymphoma and SPEN. So almost all types of cases we have seen in last 1 year. Just to summarize, EUS guided tissue acquisition has got a good success rate. Right technique and right layer is very important in acquiring proper tissue for the diagnosis. EUS FNB sample, it increased cellularity and preserve histological architecture, and it is ideal sample for histological examination and molecular testing. FNB is promising in liver biopsy, pancreas, liver, and GI tract, and a failure requires a repeat procedure, which is extremely costly. We don't want that. And Moose, again, is very promising. With using Moose, we are having high yield, and it can increase the number of post passes. We don't see such macroscopic visible complexes. Optimizing the technique is very important, and repeat procedure should be avoided. Thank you.
Thank you so much, Dr. Amit. I think we have Dr. Prashant Bhandarkar with us.
Amit, I'm Dr. Bhandarkar. Sorry I joined in late. I was supposed to.
No, it had just begun, sir.
Yeah. I just sorry, Prachi. First of all, congratulations for arranging this beautiful symposium. Very informative and very educative. And Amit, as usual, has delivered an excellent talk. He's given an excellent talk on the technique and technology for Fna and Fmb. The measures he suggested to increase the US yield were very, very useful. Audience can ask questions. I have just two questions for Amigal. Which part of that sample you sent for cytology? That's because the white tissue you say you send for biopsy. And so cytology, what exactly do you send for cytology?
So after taking out the macroscopically visible complexes, these are white tissues, also the hemorrhagic clots we take out, and whatever is remaining on the slides, we prepare smears with that remaining tissue.
The
so
thick
whatever
smears which you said.
Yes. So rarely we don't crush these samples because these are extremely helpful for making blocks and doing further analysis. So whatever is remaining after taking out that solid tissue, we prepare the slides from the remaining tissue.
One very fascinating thing you said that the yield of rows on-site evaluation by the pathologist for Fna samples and Fnb samples, it's comparable. So if your pathologist is available, would it decrease the cost of Fna with the rows or Fnb, which is more expensive?
Definitely, Fnb needles are costly as compared to Fna needles. Even a few of the companies are giving it for free. Whenever it's a buy endoscope, they will give you 50 free needles or Fna because nobody is now using Fna needles. So definitely, if you have in-house pathologist with you, Fna needles can be used. That can obviously decrease the cost of the procedure. But if you don't have, always better to use Fnb needles.
Okay, thank you.
I think we have
any questions from the audience?
Yeah, there is a question here. Is it possible to differentiate between primary and secondary pancreatic nodules by EUS, whether it is primary pancreatic or some metastasis?
As I mentioned, I showed you 4 of my patients' pictures. It's very difficult to differentiate what kind of lesion it is. So we were thinking that it might turn out to be adenocarcinoma. And surprising, that was Prashant sir's case only. It turned out to be, you already reported that case. So it's very difficult to differentiate primary versus secondary. Is the tissue diagnosis which is very important in such cases.
Right. So like you mentioned, elastography is coming up, which can identify it better. But I think chronic pancreatitis and ductal adenocarcinoma would still remain a problem. It is a problem for us also, and for I think you people also, considering the sclerosis and fibrosis that has occurred.
So elastography is it helps to a certain extent when it may identify tumors inside the hypoechoic looking mass.
Okay.
So because most of the times you are not left with any other option but to do repeat Fna multiple times.
Right. Thank you,
Amit,
Dr.
you mentioned about taking this one last question. You mentioned about taking peritoneal biopsy.
Yeah.
So
yes.
Is it done in presence of ascites or without ascites? And
so most of the time peritoneal with some form of some ascites. It's maybe mild or severe, moderate or severe ascites. So basically, rather than targeting ascites, the peritoneal nodules, which are classically seen during EOS examination. So these nodules are targeted, and it has been found to be extremely helpful, and the positive rate is excellent in such cases.
Any other comments from any of the panelists, Dr. Avni, Dr. Mukta?
Yeah, it can reduce the requirement.
I just have one comment. So you mentioned the Mohs macroscopic evaluation and picking up the white pieces of tissue. So we routinely do that. We will pick up the pieces, not crush them to make a squash prep or a smear, and put them directly with our cell block or biopsy preparation. And that has really improved our ability to diagnose adenocarcinoma even.
Yeah, we also do that. We also do that. We no longer make smears out of those.
So the smear should be made whatever is remaining after taking
So the
out the
cell block is better because it will preserve the morphology better.
Right.
And it can be utilized as well.
Right.
Rather than being on the cytology. And Dr. Agrawal, I really enjoyed your talk.
Yes.
Very nice. And I actually want to thank you for highlighting two very important developments that have happened. One is the movement from Fna to Fnb. And for a core histopathologist like myself, I know Nagpur is a stronghold of cytologists. So many people would not like this comment, but then I must, in spite of being from Nagpur, I'm a hardcore histopathologist than a cytologist. So this change from Fna to Fnb is very welcome to people like us. And secondly, the development of MOS. I think that not only, it reduces your own dependence on the pathologist. So it is beneficial for your own practice. And also it is very, very time consuming for the pathologist to do the on-site assessment. So when our residents go away, they're away from the department for a lot amount of time. So it is, I think it's a great development. And with practice, the eyes get trained even better and the MOS will get even better. So it is beneficial for both, for yourself and the pathologist too.
True.
I think if there are no more questions, thank you, Dr. Amit. Thank you so much. Thank you, Dr. Bhandekar sir, for chairing the session. Renuka, you may take over, please.
Thank you, Prachi, for having me here.
Thank you, Amit Agrawal sir, for sharing your knowledge with us. Your session was full of valuable information for the pathologist. Thank you, Prashant Bhandekar sir. Now, continuing with the third talk of the session, we have a great opportunity to listen to our dear VAPM President, Dr. Prachi Sancheti ma'am. She is the director and the consultant at Exclusive Histopathology, Cytology and IHC Laboratory in Nagpur. She has special interest in GI, hepatic and pancreatobiliary pathology, and has delivered many talks and presentations in many national and regional conferences and has many publications in index journals to her credit. Over to you, Prachi ma'am. This session will be chaired by Senior Pathologist in Histopathologist in Nagpur, Dr. Kamyani Deshpande madam. I request Kamyani Deshpande to chair.
Good afternoon, everyone. Can you hear me?
Yes, ma'am.
Yeah. Good afternoon, everyone. It's a pleasure chairing this session. The reason is there are two reasons, because we see a lot of EUS guided pancreaticobiliary pathologies. And the topic when Prachi told me she has selected, I was so glad, because it's challenging for us in a view that basically the contamination of the material, new technology, and the foremost is the complex anatomy of pancreaticobiliary and ampullary region. It's really mind-boggling when you see that things on your slides. And I'm very glad that Prachi took this topic, which is currently quite challenging for all histopathologists. And second, I would like to congratulate Prachi, that we all know she has good achievement. We are very proud of her. At young age, she has achieved a remarkable place in the histopathology in Nagpur. And I can say Vidarbha and Maharashtra, I don't know how she's presented. And she has a very keen eye. What I love about her, she has a very keen eye of observing things. And it's always pleasure listening to you, Prachi. And so I'm really looking forward today to listen to you in such a complex and a new topic. I welcome you, Prachi. Please deliver.
Thank you so much for those kind words, madam. And I really look up to you and people like Ravi sir and other renowned pathologists of Nagpur. Thank you for the kind words and encouraging words. With this, I begin with my talk today. So I think Dr. Amit Agrawal has given us a very good overview of the procedure of the EUS FNA. So it should be easy for you to understand the interpretation now. So why EUS FNA of pancreatic lesions? Because it has gained widespread popularity since the introduction of fine needle. EUS has been around, say, since 1980s, but since the introduction of the fine needle aspiration needles, it has gained a lot of popularity. It is a popular procedure for evaluation of pancreatic lesions because these lesions are difficult to approach with conventional endoscopic procedures or even percutaneous needle biopsies. Interpretation of EUS guided FNA cytology or biopsy, it is one of the most challenging tasks, like Madam said, because of the complex, very closely related anatomy of the pancreas, duodenum, the periampullary region. So it is a difficult task to interpret these samples, and it often yields minimum amounts of diagnostic material and can also contain contaminants such as blood cells as well as the cells from normal gastrointestinal mucosa. Pathologists should understand the morphological differences encountered in EUS FNA samples. They should be aware of its limitations, pitfalls, and of course, correlation with clinical and radiologic findings is very much mandatory. And we'll see that some ancillary techniques can also be used wherever applicable. So preparation method, I think, sir, as Dr. Amit Agrawal has very nicely elucidated that the direct smear method, where the aspirated material can be expelled onto the glass slides and they can be placed for cytology in alcohol fixative and air dry. And like he said, the microscopic particles are removed separately and put in formalin. Or if there are no tissue, then a pass can be made specifically, not with biopsy, but FNA needles, and put it, if you put it directly in formalin, it can be used for cell block. Some centers, there are some centers have reported use of LBC, which can eliminate the background inflammatory and blood cells. Now, I think Dr. Amit Agrawal very nicely illustrated on rapid onset evaluation also. So it had widespread appeal initially, but then, as he said, over the years, it has been realized that with the FNB needles, the inadequate specimen rate even without rows is not significantly different. So ideally 3 to 6 passes are recommended if no pathologist is available for adequacy assessment. Then let's see first what are the contaminants that we can encounter while interpreting EUS FNA sample. So it involves the penetration of gastric or duodenal wall. So you've seen that the needle will pass through the gastric wall if the lesion is in the body or tail of the pancreas, and through the duodenal wall for pancreatic head and other periampullary regions. And therefore, it can contain at least a small amount of the normal gastrointestinal mucosa, which can be an important pitfall because it may be mistaken for neoplastic epithelial cells. So this is a picture of what the normal gastric mucosa, if it comes onto your slide, so it will be looking like this in the form of large, irregular, folded, monolayered sheets. And of course, we know the gastric epithelium being the mucinous epithelium, which can be made out at the border of the sheets. Then duodenal epithelium will be in the form of sheets of these columnar cells, which will have this characteristic starry sky appearance because of the presence of the mucin containing goblet cells. Then also, apart from the neoplastic cells, you can encounter pancreatic acinar cells, and it is very important to identify them correctly. So you can see they will be in the microacinar pattern, will show abundant granular cytoplasm with eccentric nuclei. And this is a very important pitfall because very often they can be interpreted to be neuroendocrine cells and mistaken for neuroendocrine neoplasms. Then normal ductal cells, pancreatic ductal cells, the benign one can also be seen in the form of two-dimensional flat sheets with the typical honeycomb appearance or even the picket fence arrangement. And the nuclei will all be bland, and the uniform honeycomb appearance will be very much visible. Apart from this, blood and inflammation, mucin necrosis can also be seen, and mucin has got important implications, as we'll see subsequently. So once we have a sample, what is the background, what the details that we need to know? We need to know the demographic details, especially the age and sex, because we know particular neoplasms have a very characteristic clinical setting. Then the location of the tumor, the head, body, tail, whether the tumor is solid or cystic, and if it is cystic, whether it is communicating with the pancreatic duct, and then if there are any background features of pancreatitis, stones, etc. Some stenting has been done, and also the approach of the EUS FNA, whether it is transduodenal or transgastric, especially when it will help us if we encounter any normal epithelium in our smears. So as far as the solid masses of pancreas are concerned, there is a whole list, but then ductal adenocarcinoma constitutes almost 80 to 90% of all solid masses. And in my subsequent presentation also, I will only stick to the more common ones. So ductal adenocarcinoma is the most common one. Then there are neuroendocrine tumors, and of course, acinar cell, pancreatoblastoma, rarely lymphoma, plasmacytoma. So I will not be dealing with them individually, but then I will mention where they can come as important differential diagnosis. So when you get a smear of an USFNA of a pancreatic lesion, how are you going to analyze it? So let's see, what are we going to see on the low part? What is the cellularity of the smear like? Is it the cellularity is on the lower side? Is it highly cellular? What is the arrangement? Are they in the form of clusters, dispersed? What is the cohesiveness? If there are cohesive clusters, singly dispersed cells. What is there in the background? Are you seeing any necrosis or mucinous material? Then coming to the intermediate part, we'll see what are the composition of the cell groups. Are you seeing one type of cell groups, or there are more than one? How are they organized? Are they cohesive, discohesive? And amongst the clusters, is there a loss or maintenance of polarity of the nuclei? Is there any nuclear overlapping, crowding? And two-dimensional versus three-dimensional. So what we saw for the normal ductal cells, they are very, very two-dimensional monolayered sheets. But are we seeing three-dimensionality where the clusters have become more complex? And after going on high power, we'll see for the nuclear size, the nuclear contours, ANC ratio, chromatin pattern, what is the degree of anisonucleosis, and presence or absence of nucleoli. So with this background, let us see the key pathological features of some commonly encountered pancreatic neoplasms. The first being the ductal adenocarcinoma. So this will be the most common, this is the most common solid tumor pancreas, and it will be the most commonly encountered neoplasm on an USFNA. And the cellularity depends a lot upon the tumor size, location, type of the needle used, and also the endoscopist techniques. But in a typical situation, a ductal adenocarcinoma will show high cellularity smears. They will be cellular. They will be in the form of crowded sheets, three-dimensional and papillary clusters. In addition, there will be singly dispersed cells. There will be loss of polarity, enlarged pleomorphic nuclei, prominent nucleoli, and sometimes necrosis also. So like I said, a typical case would be very cellular, and on this part itself, we can see very complex arranged crowded clusters are seen, some appearing papillaroid. Then the background here itself is very dirty and necrotic appearing. And this is what is called as the typical drunken honeycomb appearance, where, like we saw in the normal ductal cells, the polarity was very much maintained. But here, the cells have gone all haywire, they're touching each other, there is total loss of polarity. And the nuclear pleomorphism, what it is said, the anisonucleosis should be to the degree of 4:1. Like it is said that within the same cluster, there should be a 4 times variation in the size of the nuclei. And you can also see the prominent nucleoli. Here it is comparing with a benign ductal epithelium. You can see very much monolayered honeycomb, but here they have all gone haywire. Crowding is there, a lot of overlapping, and the anisonucleosis, like I mentioned, is that very significant one. Within the same cluster, significant difference in sizes, and of course the nuclear outline also has become very irregular. Then if you make a cell block or in the biopsy, we can see these cribriform complicated glands, which can be seen floating sometimes. And if you've got a good core, then you can see the characteristic desmoplastic stroma with this irregular infiltrating malignant glands. So if many atypical cells are seen in a case of ductal adenocarcinoma and necrotic background, it is easy to conclusively call it so or diagnose it as malignant. But then we are more likely to encounter paucicellular smear than a higher cellular one. And sometimes only few atypical cells can be seen with or without necrosis. So at such times, correlation with clinical and radiologic impression is very important. So like I said, there can be just few atypical cell clusters in the necrotic background, also in the cell block. Such kind of floating atypical cells, glands can be seen in similarly here. But then in such situation, what is going to help us indicate or suggest malignancy if there is a lot of cribriforming of the glands, there is nuclear stratification, there is the loss of honeycombing, overlapping and touching nuclei, significant amount of anisonucleosis, and apart from the clusters, if there is a good number of scattered small clusters or singly dispersed atypical cells, that would indicate towards malignancy. Also, a word here about ductal adenocarcinoma versus chronic pancreatitis. Now, like Dr. Agarwal said, that there is a whole lot of clinical as well as radiological overlap between ductal adenocarcinoma and chronic pancreatitis. Also, we know chronic ductal adenocarcinoma can develop in the setting of chronic pancreatitis, but chronic pancreatitis would be mostly paucicellular smear. There will be mostly ductal cells. Some islet cells can also be seen. So there will not be just one cell type. You can see some islet cells also. And characteristically, the benign ductal cells will be in the form of monolayered sheets. They will be cohesive. You will see very few single cells, maintain polarity with minimal nuclear overlap, very mild anisonucleosis, smooth nuclear membrane, which is very important, and no necrosis and very rare mitosis. So this is just for comparison. This is a very, in chronic pancreatitis, a bland or monolayered sheet of ductal epithelial cells. Mind you, some reactive change in the form of some nuclear enlargement and prominent nucleoli may be there, but still the polarity is very much maintained and the nuclear membrane will be very much regular, whereas this is well differentiated pancreatic adenocarcinoma. So you can see although there is not, you cannot say very large pleomorphic cells, but then there is a good amount of overlapping, crowding, and touching nuclei, what they call, and with regulatory nuclear membrane also noted. So also, if you're seeing only necrosis, then it should not make you call it ductal adenocarcinoma, because we can also see in other lesions, especially tuberculosis, which although rare in the pancreas, is not unheard of, especially in our country. And sometimes neuroendocrine tumors and also solid pseudopapillary neoplasm can show some amount of necrosis. Coming to neuroendocrine neoplasms. So neuroendocrine neoplasms are also going to show you good cellularity. However, here they are going to be in the form of loosely cohesive cell groups. There would be rosette or pseudo-rosette formations, and the cells are going to appear uniform. In the previous case, in ductal adenocarcinoma, they were very pleomorphic, lot of anisonucleosis, but here they're going to be relatively uniform, round to polygonal tumor cells, plasmacytoid cells, and characteristic neuroendocrine salt and pepper chromatin with or without nucleoli. So something like that, singly dispersed cells, you can see rosettes, very uniform appearing cells, round to oval nuclei, sometimes even spindle, and very, very fine chromatin. Then in the cell block, or if you get a biopsy, this you can get a good trabecular arrangement or organoid nesting, whatever is present. But then, of course, neuroendocrine neoplasms have to be subjected to immunohistochemistry for confirmation of neuroendocrine differentiation. The markers that we can use is synaptophysin, chromogranin, CD56, and SM1 is a relatively new marker. Then Ki-67 proliferation index is important for grading. I am not going into the detailed grading of pancreatic neuroendocrine neoplasms, but then it is important to do it so as to convey to the clinician and to decide them so that they can make up their mind of how the disease is going to behave and the mode of therapy. High-grade neuroendocrine neoplasm can show a good amount of pleomorphism, but then still some fineness of chromatin can be seen, and they will be pleomorphic and with and also can show necrosis. So they will show hyperchromatic cells with or without necrosis, and in such cases, possibility of metastasis from small cell carcinoma should be excluded based on the clinical history, and immunohistochemical evaluation should also be done. Then a very important differential diagnosis of neuroendocrine neoplasm, especially on cytology, will be a solitary pseudopapillary neoplasm, which can also show discohesive plasmacytoid cells. And as we're going to see subsequently, the papillae, the myxoid papillae that are seen in SPN may not always be visible, and so just the discohesive cells may be present. So radiological features can help, although neuroendocrine can also show cystic chain. Solid pseudopapillary will be more cystic, and then immunohistochemistry need to be resorted to. So the idea is that it's always, in fact, it has become imperative to get tissue for biopsy, and so that we can use the immunohistochemistry or any other test subsequently. Then, like I said, there are other solid neoplasms as well. For acne cell carcinoma and pancreatoblastoma, both can form an important differential diagnosis for neuroendocrine neoplasms, because the acne cells can be mistaken for neuroendocrine cells. But then pancreatoblastoma can show the squamous squamoid cells if they are seen typically. Lymphoma, plasmacytoma rare, but then again plasmacytoma, we have already talked that plasmacytoid appearance in neuroendocrine neoplasm, so can be a differential diagnosis. So a lot of clinical history and radiological appearance will make a lot of difference. Metastasis, although rare, can be seen. Coming to cystic neoplasms. So amongst this cystic, these are not very common. These are rare neoplasms. To list these few, so intraductal papillary mucinous neoplasm, mucinous cystic neoplasm, serous cystic, solid pseudopapillary, and non-neoplastic can be the pseudocyst of pancreas. So amongst the cystic neoplasm, it is important for us to know what is the location, then whether the cystic neoplasm is communicating with the pancreatic duct, is there a mural nodule, and whenever there is any fluid aspirated, it is subject to Ca level estimation. So whether it is raised or not raised, because Ca level raise indicates mucinous neoplasm. So intraductal papillary mucinous neoplasm is one of the most common pancreatic cystic neoplasms. It can be the main duct or branch duct type. It has got a typical radiological appearance. Like they said, it should be you should be able to get the details of whether it is communicating with the duct. And US Fna is performed here to evaluate the grade of cytologic atypia. So they can show varying degree of atypia or can have an associated invasive carcinoma also. So IPMN will characteristically show the mucinous background with papillary clusters of columnar epithelial cells, which will be containing cytoplasmic mucin. And this becomes very important if we are seeing any contaminant of gastric mucinous cells, and they can be mistaken for this IPMN. So it is important for us to know the location of the tumor, know the approach of the USFNA, whether it was transgastric or transduodenal. And of course, these can show varying degree of epithelial atypia. So a lot of mucinous material may be seen, and these papillary clusters, which can be from benign to varying degree of atypia, can be seen. Again, the atypia is very similar to what we see in colorectal polyps. That can be low grade or high grade, and based upon the cytology, we are supposed to convey whether it is showing low grade or high grade atypia, and whether there is any invasive carcinoma along with it. So like I said, it can be difficult to differentiate the papillary nest from the contaminated intestinal mucosa. Then the branch duct type, which has gastric foveolar type epithelium, can be difficult to differentiate from contamination by gastric mucosa. So it is important to assess the anatomical location, and radiological features should always be looked into. Serous cystic neoplasm is not very common, a very low cell diameter. Sometimes you can just see some cyst fluid with some serous kind of bland epithelial cells. Mucinous cystic neoplasm are mucinous neoplasms which are not communicating with the duct, and these can also show varying degree of atypia, like we mentioned in that of IPMN. So atypia has to be commented upon, cannot mostly convincingly diagnose mucinous cystic neoplasm. So basically, in cystic neoplasms, what are you supposed to convey, whether it is mucinous or non-mucinous, and if you're saying an atypia, whether it is low grade or high grade, and if you can see frank malignancy along with it, definitely you're supposed to report it. Coming to a very unique tumor of the pancreas, which is the solid pseudopapillary neoplasm of the pancreas, which has got a very characteristic clinical setting of middle-aged or rather young to middle-aged female with mass in body or tail of pancreas. It is a very solid, cystic, well-defined mass on radiology, although it is of a low malignant potential, but very well-defined on radiology. So the FNA smears will be very hypercellular. And again, this is going to show you a lot of discohesive cells with plasma cell-like features. Like I said, a good amount of overlap with the neuroendocrine tumors. But then here, if you can identify the myxoid pseudopapillae, then they will definitely help us indicate the diagnosis. Then there will be fine chromatin, nuclear grooves, and there can be intracellular hyaline globules. Some mild degenerative atypia can also be there. So in SPN, the solid pseudopapillary neoplasm, so very, very discohesive cells. So if you can see this kind of pseudopapillae, this is very good. Otherwise, if you're just seeing these discohesive kinds of cells with plasmacytoid features, it can be very, very difficult to differentiate them from neuroendocrine neoplasms because the chromatin will also be very fine, and sometimes you can identify grooves as well. This is what the histology is. So basically, it is not really cystic, but what happens is that the cells away from these blood vessels, they tend to degenerate, and they become discohesive, giving it a appearance of a cyst. So this is solid papillary neoplasm. Scattered pleomorphic or bizarre cells can be seen, but they reflect degenerative changes. Main differential diagnosis will definitely be a neuroendocrine tumor. And in this case, IHC plays a very important role, and especially the demonstration of the nuclear beta-catenin positivity will help indicate a diagnosis of solid papillary neoplasms. And where sometimes they can show clear cell change, which can mimic metastatic renal cell carcinoma. Pseudocyst is just going to show us hemorrhagic inflammatory debris, no epithelial cells. It can be, and of course, there will be a background or a history of pancreatitis, trauma, or any surgery. Now, metastatic tumors, they're difficult to evaluate because pertinent clinical information is very much essential. Renal cell carcinoma is one of the most common metastatic tumor in pancreas. Metastatic small cell carcinoma from the lung, it may be difficult to differentiate from high-grade neuroendocrine carcinoma of the pancreas. Immunohistochemistry does play an important role here. This is the Papanicolaou cytopathology system for reporting pancreatic biliary cytology, which can be used not only for USFNA, but also from biliary brushings, ERCP brushings, transcutaneous FNAs, or even brushing cytology. So what are the ancillary tests that you can be used on FNA samples, USFNA samples? So immunohistochemistry on the biopsies or cell blocks is the most widely used method, especially in neuroendocrine tumors. You have to demonstrate the neuroendocrine differentiation with the typical markers in solid tissue papillary neoplasm, like I said. Acinar cell neoplasm will show positivity for trypsin, chymotrypsin. Then not very commonly, but sometimes these markers, P50, SMAD4, CA, they can differentiate between ductile adenocarcinoma and reactive epithelial cells. Molecular tests, although are not widely being used, but then they can be performed on cyst fluid or on the cell blocks in biopsy. So especially in cases of unresectable pancreatic cancer. Pancreatic cancers, we know, are very commonly associated with KRAS mutations, and especially in inoperable cases. So the baseline is that you have to archive or preserve as much tissue as possible. So it is very important to make cell blocks, and if you're getting good chunks of biopsy, there can be nothing better than that. With this background, let us just discuss a few very typical cases for that matter. So this was a 64-year-old female with a solid mass in the head of pancreas. EUS guided transduodenal FNAC and biopsy was performed. So we can see that it has got a good cellularity, and some papilloid crowded epithelial clusters are seen. And in fact, we can also see some fibrous stromal fragments there in hemorrhagic background. And on hyper, they were very, very crowded clusters with a good amount of nuclear pleomorphism, overlapping, even single atypical cells in the background, as you can see. So this was the biopsy, the cribriform atypical malignant glands, and then there were these areas which were showing the infiltrating malignant glands with the characteristic desmoplastic stroma. If you're lucky enough, sometimes you can see perineural invasion as well. So this was a case of a ductal adenocarcinoma. The next case is of a 65-year-old male with the EUS-guided FNAC and biopsy of ampullary mass. So of course, this is not from the pancreas, but then I guess pancreatic, ampullary, and duodenal, they can always be clubbed together and are mostly subject to EUS-FNA. So this one, so here itself you can see the rosettes and the disc cohesive kind of very, very uniform cells with the round oval nuclei, fine chromatin. This was the FNA, and the biopsy is showing nicely the nest of cells surrounded by the blood vessels, very uniform appearing cells with fine chromatin, round cells with plasmacytoid appearance, and round nuclei with fine chromatin. So this was a well-differentiated neuroendocrine neoplasm. It was, of course, subject to IHC eventually, and it showed positivity for synaptophysin and hemogranin. Ki-67 was 1%, so it was a well-differentiated neuroendocrine tumor, WHO grade 1. This case 3 is a very interesting case. So this was a 33-year-old male with EUS-guided FNAC and biopsy of pancreatic head mass. So young male, the doubt was whether it is malignant. So what are we seeing here? So as you can see, cellularity is good. This is a giant cell, scattered inflammatory cells, some clusters, not really looking epithelial. It was showing necrosis as well, and then there were a good amount of epithelioid cell granulomas, even some degenerated epithelial cells, epithelioid cells around these necrosis can be seen. This was the biopsy showing necrosis And if you can see here, these somewhat crushed, but then there are these epithelioid cell granulomas, Langerhans giant cell over here also. So epithelioid cell granulomas, it was a case of pancreatic tuberculosis. So like I said, it is not unheard of in our setup, and it should always be at the back of our mind. Now, this is not a US guided biopsy, it is a USG guided biopsy, but of a very peculiar lesion of the pancreas. So I thought of including it. So from here, this thing itself indicates the diagnosis: a 20-year-old female with a well demarcated hypodense lesion in the body of pancreas. It was a USG guided biopsy, and so nicely it showed the myxoid pseudopapillae surrounded by these sheets of cells, which are kind of getting discoesic and falling off away from the papillae. So very uniform appearing plasmacytoid kind of cells. There are these solid sheets also. Here the papillae can be seen, very fine chromatin. So here this on this itself, of course, I thought of a solid pseudopapillary neoplasm, and it was subject to IHC. So IHC is also important because, like I said, the main differential diagnosis is neuroendocrine neoplasm. However, SPNs can also show synaptophysin positivity. This was positive for synaptin, but negative for chromogranin. But what is important is to demonstrate this beta catenin nuclear positivity, not just the cytoplasm. It has to be in the nucleus for and of course it shows CD10 positivity as well. So this was a solid pseudopapillary epithelial neoplasm of the pancreas. This is an interesting case. In fact, it has been contributed by none other than Dr. Kamini Deshpande, madam. Like I said, USFN is not just restricted to pancreas. It can be used for very mediastinal lesions, peripancreatic lesions. So it was a pre-caval mass, which turned out to be a paraganglioma, very interesting typical morphology. But then again, you have to be very much aware of the location. Then it was also, of course, eventually confirmed on IHC, then the location and what is the mass. And in fact, this patient has had the history of variation in the blood pressure while doing the procedure. So what about correlation of radiologic findings while interpreting USFNA? So sometimes fewer typical cells insufficient for making a conclusive diagnosis of malignancy can be seen. However, in a clinical setting with multiple liver metastasis, peritoneal seeding, possibility of malignancy can still be suggested. But if the setting is that of chronic pancreatitis, pleural malignancy, it may then be labeled properly as a typical cell of uncertain malignant potential. In a clinical setting of malignancy, if USFNA does not provide a typical cell, then before calling it negative, you should suggest the possibility of non-representative sample in the report. In fact, pathologic confirmation of a true negative is more difficult than confirmation of a true positive. So to conclude, USFNA cytology biopsy for pancreatic lesion has become more routine in daily practice. Pathologists should be familiar with the potential pitfalls while interpreting these samples. Knowledge of clinical and radiologic findings is essential to make an accurate pathological diagnosis, and ancillary tests can come to your rescue as supportive evidence whenever required. Thank you.
Excellent talk, Prachi. Once again, congratulations. The clarity of your thoughts, I really admire that. And it can only come when person has worked so into and seen so many conditions, that clarity to approach towards the slides. Thank you for sharing your knowledge with us. A small comment I want to make. I agree with Dr. Mukta that we also encourage in the US and all that we preserve as many as tissue in formalin rather than squashing into the slides. But being in students of Maitre Munshi madam, I'll tell you, Mukta, that it's still a pleasure when we get an FNAC from such a difficult anatomical sites with contamination. I remember madam teaching stick to the criteria of nuclear abnormalities, nucleoli, nuclear membrane, and it really helps us to, at least guide the clinicians that we are looking either into a malignancy or non-malignant lesions. And I would like to share one case of mine, which I saw just the last week, that again, it was a head of pancreas, mass head of pancreas on radiology. And when I got the slides, there were a lot of papillary clusters resembling intestinal mucosal. And I just suggested randomly that I'm not very sure, but it could be a papillary lesion of ampulla. And when excision came, it turned out to be an ampullary papillary neoplasm. So the thing is, when you see something and you observe something, and if you resemble that thing and identify it with some anatomical features, I think you should at least suggest the clinicians, guide the clinicians for that, rather than hesitating and stopping yourself, because it sometimes helps the clinicians to plan, surgeons especially to plan, because I insisted that this can be an ampullary and not a head of pancreas maybe, but that helped them to plan some things. So excellent talk, Prachi. Thank you so much. And if there are any questions, I think Prachi can take it.
Nothing in the question answer
I
box.
think there are no questions. Any questions from the audience?
No, I don't think there are any, Renuka. I think you can go ahead.
Okay. Thank you, Prachi ma'am, for very interesting presentation. Thank you, Kamyani Deshpande ma'am, for moderating the session. Moving on to the next, or the last lecture of the session. I would like to invite Dr. Padmaja Achanta ma'am. She is a consultant histopathologist at Kavya Pathology Lab, Nagpur, with special interest in oncopathology and GI pathology. She has been trained at Indo-American Cancer Hospital, Hyderabad. I request Dr. Mahesh Deshmukh sir, who is a senior surgical pathologist and consultant at Alexis Hospital, Nagpur. Over to you, Padmaja ma'am.
Yeah, am I audible, Renuka?
Yes, ma'am, you are audible.
Very good afternoon to one and all. First of all, I would like to thank the organizers of VAPM for giving me this opportunity to share my experience. I'll start sharing this.
We have Dr. Mahesh sir online, right? Yeah.
Yes, ma'am, we are, Mahesh sir is there.
Okay.
Please continue.
Yeah.
Yes, sir. Yeah, thank you. And after listening to all the wonderful speakers, how to make a diagnosis from a minimal tissue, now we have the entire specimen on table. I'll be dealing with a very basic topic, and I'll be sharing my experience and how to gross a liver, gallbladder, and Whipple resection specimen, how to gross in a simple and efficient way. First of all, I'll be starting with the Whipple resection. Brief history. Dr. Alan O. Whipple was the first surgeon to record the on-stage procedure, which included removal of pancreatic head along with the stomach, duodenum, and just a minute. Stomach and CBD to treat patient of carcinoma head of pancreas. Dr. Hyde and Dr. Koch also published data widely about the procedure. And classical Whipples was initially a two-step procedure, which got modified into a single-step procedure subsequently. Pylorus preserving pancreatoduodenectomy is the procedure widely used currently. Indications for Whipple surgery. It is a radical surgery for operable neoplasms of tumors of, here in this diagram we can see, tumors of ampullary and periampullary regions, tumors of head of pancreas, tumors of the distal CPD, tumors of duodenum near pancreas, and rarely some cases of chronic pancreatitis. Why grossing is so important, especially for Whipples. Pathological staging is the single most important purpose of grossing any oncology specimen, which makes grossing meaningful. And here comes, this is a specimen of Whipple resection. Components of the Whipples. There are two types of surgical specimens we'll be receiving. One is the standard Koch Whipple's pancreatoduodenectomy specimen, which have a distal stomach. And second one is pylorus preserving pancreatoduodenectomy, which is also called PPPD, which has a duodenum. This is the C loop of duodenum, head of pancreas, CPD, gallbladder, and regional lymph nodes. Gallbladder will be sometimes present, presented along with the same specimen, or it can sometimes be sent to a lab as a separate specimen. This is a picture of a gross picture of a Whipple resection. This is the C loop of the duodenum. This is the head of the pancreas, CBD somewhere, and this side will be pancreatic neck. This is the C loop of the duodenum. This is the head of the pancreas, and this is the SMV, and this is SMA, which I'm going to see in a few minutes. What am I supposed to tell a surgeon? First, status of the surgical margins, site and extent of the tumor, and status of lymph nodes, which is an independent prognostic marker. Lymph nodes will be present in situ in the specimen, and sometimes they'll be sending as a another specimen. These are some of the pictures of Whipple's resection, how it looks like, and this is a closer look at the proximal end. One, status of surgical margin. So resection margin is a key prognostic factor in pancreatic, especially in pancreatic carcinomas. Positive surgical margin is associated with very poor prognosis and may be given adjuvant chemoradiotherapy. And median survival rate of patients with positive margin is the same or worse than that of the patients with unresectable tumors. Next, site and extent of the tumors. Determination of the epicenter of the tumor, whether the tumor is in the apella, periampullary, duodenum, CBD, pancreatic duct, or head of pancreas is very crucial, as these tumors are biologically discrete entities and careful gross examination and meticulous sampling is essential in identifying the primary site of origin of the tumor. However, it may not be possible to accurately determine the origin of this tumor, especially when the tumor involves more than one anatomical site. Coming to the status of the lymph node, it provides input for TMS. Adequate lymph node sampling is one of the most important predictors of survival in pancreatic carcinomas. And there are various number of lymph nodes that should be submitted, but all the guidelines recommend that examination of at least 12 lymph nodes for accurate staging to say it as P and 0. What are the prerequisites before taking up a grossing, before going to the grossing table of a Whipple resection? Know your anatomy, check radiology, and no pathological stage. We all know this anatomy. I'll be just briefly telling you about this. This is a right and left hepatic duct. This is the which forms a common hepatic duct. Along with the cystic duct, this forms the CBD. CBD comes out of porta hepatis and it dips into the pancreas, posteriorly comes down. It is joined by a main pancreatic duct, and it opens into a duodenum by forming an ampulla of Vater and through a papilla. This part is resected in the Whipple's tumor. This becomes the proximal resection end, and this becomes a distal resection end. After this, the anastomosis is being done. And this is one more diagram to showing how to define the head, body, and tail of the pancreas. This is superior mesenteric vein. Along with the inflammation, it forms a portal vein. So tumors in this area will be designated as tumors of the head of the pancreas. And this is the aorta. And this area will be designated as tumors of body of pancreas. And the terminal part is the tail. Then steps of crossing: first, orient the specimen and inspect the specimen, ink the specimen, resect the margins, open the specimen, sections, give sections by histology, and finally, do a lymph node dissection. First, orientation of the specimen. Orientation of the specimen is very, very important sometimes because it's not always, we don't always get a very good sample. Sometimes because of the fixation, and they'll be packing these things in very small bottles. It will be sometimes very difficult to identify proximal and distal ends also. Identify various components, identify different surfaces, record the dimensions for stomach, record greater and lesser curvature, for duodenum length, pancreatic head, all the 3 dimensions have to be mentioned. For CBD, length, diameter, and wall thickness of the stump is very important. And document the presence of stent and vessels, if any, are present in the specimen. Then we need to identify the surfaces of the head of pancreas. There are 3 main surfaces: anterior, posterior, and medial. The medial has 3 parts: neck, SMV groove, and SMA surface, which is also called retroperitoneal margin or uncinate margin. This is the anterior surface. This is very smooth and almost it's like a bulging surface. There will be fat here, and this is the posterior surface, somewhat flattened and roughened. Before going to the medial surface, we just need to understand a bit on a relationship of the head of pancreas and superior mesenteric vessels. There is a close anatomical relationship between head of pancreas and the superior mesenteric vessels. Superior mesenteric vein, along with the superior mesenteric artery, which is present to the left of the superior mesenteric vein, they hook under the pancreatic neck and ascend posteriorly. So this, after transecting the neck, the superior mesenteric vein, it forms a very smooth, glistening curvilinear tract, and it indents the specimen. And SMV, this is the SMV groove, which we can see. This is the medial surface, and this is a very smooth, glistening tract, which was created by SMV. This is called SMV groove. And there's a small triangular patch, which is called also called a retroperitoneal surface or retroperitoneal margin, or a SMV surface. And this is the pancreatic neck. Next, ink the specimen. There are various protocols to choose your ink. Different institutes and different labs can have their own set of colors and multicoloring ink protocols. This is a specimen showing a blue anterior surface, orange SMV surface, black retroperitoneal margin or SMV surface, or green posterior surface. The ink should be allowed to dry before fixation and fix the specimen further for 24 hours. After inking, you have to just take the resection margin and then further fix the specimen for 24 to 48 hours. If it is a proximal CBD cancer, inking of the radial soft tissue surfaces surrounding the CBD at the superior aspect is necessary. Next, resection of the margins. We all know there are two types of margins mainly. One is a shape or margin which is parallel to the plane of resection and embedded in such a way that ink surface first cut and represents the edge of the resection. And second one is radial or perpendicular margin. It permits the measurement of exact distance of the margin from the tumor. This is a pictorial diagram which is showing this is a shave margin and this is a radial or perpendicular margin. Here comes there are steps for margin resection. Shave margins. This is a proximal or pylorus margin. This is a distal or duodenal margin. This is the CBD margin. And pancreatic transected neck margin and retroperitoneal uncinate margin. These are all taken as a shave margins. And take a radial margin if the tumor is close to any of the margins. Resection margin. And other margins are anterior pancreatic margin, posterior pancreatic margin, SMV groove or vascular surface, and proximal and distal ends of the vessels if they are submitted. This is the posterior pancreatic margin, and this is the SMV groove or SMV margin. This is the retroperitoneal margin, and this is the pancreatic neck margin. All these margins or all these surfaces are covered with peritoneum, hence these are surfaces rather than margin. And it is important to document their involvement because it is presumed to be significant for the risk assessment of a local tumor. Take radial sections whenever the tumor is close to one of the surfaces. And proximal or at the proximal end, if it is a pylorus preserving pancreatic specimen, staples will be there. The tissue with staples is neatly resected with scissors, keeping as close to the staple line as possible. And subsequently, the tissue next to this is submitted as margin after applying the ink. This is how you take a stomach proximal margin. This is the distal duodenal margin. This is the CBD margin. This is a pancreatic neck margin. And this is the retroperitoneal margin. It is taken as a shave margin. And it's better to submit all the serial sections like this. And next comes how to open the specimen. Open the duodenum along the antemesenteric border away from the ampulla. Identify the ampulla and look for any tumor or mass. Place a prop through the ampulla and try to trace up to the CBD opening. This should be done in a very gentle way. Sometimes there will be a stent will be placed, and because of distal CBD tumors and pancreatic head tumors, there could be a bit of fibrotic changes and long-standing changes. So we should be very gentle to guide the probe through the CBD. There are two methods of opening the specimen. One is bread loafing and bivalving the pancreas. This is identify the location of this is a tumor showing this is the ampulla. Already there is an in-situ stent in this, and this is how you place it on the ampulla and gently guide it, and it's coming out of the CBD. Identify the location of the tumor and epicenter. Trace the CBD and open it till then, and trace the pancreas. And this is how to open a duodenum, anti-mesenteric. This is the anti-mesenteric border of the duodenum. And bread loafing method, and make perpendicular sections to the CBD, plane of the CBD. Make perpendicular sections. This is how you make. And this is how you slice the entire specimen. The advantage is that you first, after locating the tumor, you can identify the distance to the SMA. This is how you'll, after serially arranging the different slices, it will be easy for us to identify the distance to the SMA margin, and all other surfaces. This is how this will be done. This is duodenum, this is the CBD, and this is the tumor. And second thing is it's a bivalving of the pancreas. After placing the probe, we have to just bivalve the pancreas into two. Then have to take sections for histology, 4 sections from the tumor. A tumor along with the CBD, tumor with ampulla, tumor with duodenum, and tumor with pancreas. This is very important because for all reporting protocols, we have to mention the primary site of the tumor and the extent of the tumor. And if no tumor is identified post chemotherapy, multiple sections should be taken for areas, and sections and duodenum, pancreas, and CBD and gallbladder should be taken. This is how the sections look like. This is the duodenum along with the tumor. This is the normal pancreas. This is the terminal CBD tumor with pancreas. And this is also a CBD tumor. This is the duodenum, the submucosal glands. And you can see the tumor is infiltrating. This is a pancreatic tumor infiltrating into the duodenal wall. And coming to the lymph nodes are present at the anterior. This is the anterior pancreaticoduodenal surface, anterior pancreatic surface. It's around the common CVD. Superior aspect of the pancreatic head in posterior pancreatic duodenal surface, posterior pancreatic surface, retroperitoneal or uncinate margin, and inferior aspect of the, this is the inferior aspect of the pancreatic head. And these are some of the areas where you can find this lymph nodes. This is the posterior surface. The lymph nodes are not easily available from outside, as peripancreatic fat can be thin and covered with serosa. Search for lymph nodes in every single centimeter of adipose tissue. Don't forget to search in the pancreaticoduodenal groove and search diligently. You will be surprised by the field. And tumor deposit in peripancreatic soft tissue is always, remember, this will be a T4. Here, this is a section, this is a terminal severity tumor. There is a bit of after resection. I was really surprised to find this. There is a gray white tumor nodule. This is the HE section. It is showing in the peripancreatic fat tumor deposit. And coming to some of the tumors and tumors of ampulla, ampulla is formed mainly, it's formed by the terminal CVD along with the pancreatic duct, forms almost ampulla over here, and it's opening into the duodenum. And here you can see exactly there are 3 to 4 types of ampullary tumors. Exactly defining the site of the tumor is a bit difficulty. And as you see, this is the ampullary ductal tumor, and whereas this is the intraduodenal. This tumor is an intraduodenal origin. And this is a CT picture of how it's showing. It's an ampullary tumor. And the ampullary region carcinomas are comprised of 4 distinct types. Intraampullary papillary tubular neoplasms is associated carcinomas are characterized by this gray one is the pre-invasive lesion, and the black one is the invasion. Pre-invasive component that goes as exophytic mass within the ampullary channels. The tumor will be so small, sometimes it will be around only less than 1 centimeter. Sometimes it will become very difficult. So meticulous grossing is very important to identify these tumors. And next, carcinomas of ampullary ducts are predominantly invasive tumors that circumferentially constrict the ductal distal end of the CVD and pancreatic duct with minimal papilla of Pater and ampulla duodenal mucosa. Next comes the ampullary duodenal carcinomas, usually arises from the adenoma of ampullary duodenum, forming bulky lesions within the ampullary orifice. And the ampullary orifice will be distal, in this is eccentrically located. And tumor arises from the papilla of Pater itself, as well as not showing features of any of the other groups are called as ampullary carcinoma NOS, which are very common. And this is the pathological stage of the ampullary tumors. T1 is tumor limited to the ampulla of Vater or sphincter of Oddi. T2, when the tumor is invading the duodenal wall, it goes into T2. When the tumor invades pancreas, it is 3-3. And tumor invades peripancreatic soft tissue or adjacent organs, it is T4. Next, this is to show how this is the T1 tumor limited to the ampulla. T2, it's crossing the sphincter of Oddi and going into duodenal mucosa. This is T2. This is T3. It's going into pancreas less than 5 centimeters. And T4 is there's an extensive tumor. It's going into adjacent structures. These are some more pictures of a very closer look at this is an ampullary tumor. This is a distal CVD, and this is a tumor in the ampulla. This is one more tumor, large, after opening the section, there is a large exophytic mass in the ampulla. And I just want to show some interesting cases. This is a tumor in the ampulla, and the duodenum is showing some ulceration, duodenitis in the proximal end. And this is the low part tumor. This is the duodenal mucosa, and underneath it is showing the tumor cells in sheets and trabecular patterns. In high power, we are able to see very round to oval cells, very well defined, arranged nest, tumor nest. IHC was done for this tumor at synaptophysin and chromogranin were positive, CKM were negative, and Ki-67 was low. The diagnosis was ampullary neuroendocrine tumor grade 1, and the pathological stage was T2 and 0M0. And this is one more tumor. This is the radiology picture. There is a terminal CVD. The CVD is dilated, and there is a terminal cutoff sign, which they say this indicates that there is some tumor in the distal or ampullary region. This is the gross picture. This is large mass around 5 centimeters with a stent in situ around the ampulla. And these are the pictures. We can see a lot of pleomorphism, mitotic figures, cells separated by thin fibrous septae. This is a closer look, and you can appreciate the pleomorphism here or there. And tumor invading, the tumor was growing close to the duodenum, and this is a tumor in the pancreas. And IHC was done, and synaptophysin and chromoglobin were positive. Pan-CK was focally positive. CD99 CK anemia were negative, and Ki67 was almost 80%. The diagnosis was an ampulla of neuroendocrine carcinoma, high grade. Pathological stage was T3N0M0, the tumor duodenal mucosa. Ampullary neuroendocrine neoplasms are not very, very common, and they comprise about 2% of the periampullary malignancies and less than 1% of the GI endocrine malignancies. And neuroendocrine tumors without invasion and diameter of at least 2 centimeters. And one more thing, it's as I said, intraampullary papillary tubular neoplasms. This was a very small tumor around the patient presented with obstructive jaundice, and he was investigated multiple number of times. And after doing a Whipple resection, there was a small tumor around 0.8 to 1 centimeters in the ampullary region. This is the itchy, closer look of low part, and this is the high part. And these are the various protocols for reporting. We need to mention the type of procedure, whether it's ampullectomy or a Whipple resection. We have to mention the tumor site, intraampullary or intraampullary papillary tubular neoplasm, ampullary ductal pancreatic or periampullary carcinoma. And margin status for invasive carcinomas is very important. And closest margins, which is the closest margin, these are different margins. And distance from invasive carcinoma, the closest margin should be mentioned exact distance in centimeters. Coming to the tumors in the distal CBD, this is a radiology picture of a patient who again presented with obstructive jaundice and weight loss. This is a filling defect, and this is MRCP image. So this is the dilated CBD, and this is initially the unopened specimen was looking like. A probe was placed in the ampulla, and after cutting open the CBD, there is a small tumor in the distal end. Much more closer look at the specimen. This is the mass in the CBD. And reporting terminology same. We have to mention the procedure, whether it's a pancreatic duodenectomy with resection or segmental resection. Sometimes we only see a segmental resection of the bile ducts depending on the site of the tumor, and colorectal resection. We have to mention whether the common bile duct is in whether the tumor is in the extrapancreatic area or in the intrapancreatic area. And we need to tell about all the surfaces. And this is the bile duct carcinoma staging. T1 is it invades the bile duct wall within depth of less than 5 mm. T2 it invades the bile duct wall with a depth of 5 to 12 mm. And T3 tumor invades the bile duct wall with a depth greater than 12 mm. And T4 tumor involves celiac axis, superior mesenteric artery, and of common hepatic duct category. And N1 is 1 to 3 regional lymph nodes, and N2 is metastasis in 4 or more regional lymph nodes and distance metastasis. One more thing, a pancreatic tumor is a very simple pancreatic tumor. This you can see there is a cystic lesion in the head of the pancreas. This is an anterior surface, and posteriorly there is a cystic mass in the upper surface of the pancreas. After cut section, it was showing large multiple cysts. Then this is the staging for pancreatic tumors, and T1 tumors are less than or equal to 2 centimeters in greatest dimension. This is the tumor in the head of the pancreas. T2 tumor greater than 2 centimeters and less than or equal to 4 centimeters and greater dimension. And T3 tumors are tumor greater than 4 centimeters in the greatest dimension. And T4 tumor involves the celiac axis, any of these celiac axis around these vessels, and or the superior mesenteric artery or common hepatic artery. N0 metastasis, N1 is metastasis to 1 to 3 regional lymph nodes, and N2 is metastasis in 4 or more regional lymph nodes. And yeah, this is a happy emoji showing that I'm done with Whipple's crossing, and a few more slides to show distal. Sometimes we get a distal pancreatectomy along with the spleen for tumors in the tail of the pancreas. And again, we have to just orient the specimen, and this end, this cut margin will become the surgical resection margin, and the tumor has to be sliced perpendicular to the axis of this. We have to separate the spleen. And this is how we are supposed to take sections. These are the sections along with the tumor and normal pancreatic tissue. And this is one more specimen of a distal pancreatic specimen. And this is actually a cystic mass. It was attached to the spleen, and the cut section was showing all hemorrhage, and it's a large cystic mass with a lot of hemorrhage and necrosis with a thin rim of tumor in the periphery. And coming to the grossing of liver specimens, same as such as we know for ripples, we need to know the anatomy of these various segments of the liver. I'm not going into many details, and usually we get the type of specimens, total hepatectomy, which is not very common. Partial hepatectomy, we usually get specimens of liver tumors as partial hepatectomy specimens, and sometimes a segmentectomy. For neoplastic and non-neoplastic conditions and tumors of gallbladder, we get a liver margins, liver parenchymal margin in the margin, and seriously slice the liver perpendicular to the margin. And distance, we need have to mention distance of the tumor from the margin. This is how you slice the liver, and we take a photograph of different slices. There is one more liver resection. This is a cholangiocarcinoma, and this is also peri-hilar cholangiocarcinoma. Partial hepatitis specimen was received. This is the liver parenchymal margin which was inked. And coming to the grossing of gallbladder, sometimes we may have some surprises from the gallbladder, expect the unexpected. And type of specimens, we basic cholecystectomy, part of a Whipple resection. Sometimes we receive gallbladder along with a common hepatic duct, and it could be a part of a liver resection. A margin, cystic duct margin, and sometimes it is associated with the liver parenchymal margin has to be mentioned. And this is a MRCP image of this is the gallbladder, and this is the this solid area or dark gray area is a tumor. This is how you resect the gallbladder. This is the cystic duct. Take a margin. This is the cystic duct shave margin, and serially slice it perpendicular to the long axis. And this is the rough serosal surface for a gallbladder specimen. This is the cystic duct margin. And this is one of the specimen which I've received. Initially, this was resected before resection. Radiologically, it was reported as a Cori CBD tumor. After opening the specimen, there was a large tumor in the gallbladder, which was like from the it was spreading from the fundus to all over, and it's going into the CBD. And one more, this is a partial hepatectomy specimen, which was received, and this is the surgical ink margin. And after serial cut sections, there was this nice tumor in the, actually this was a gallbladder carcinoma. Here we could see the remaining normal gallbladder, and this is a huge tumor with attached liver. And this was sent for immunohistochemistry and was confirmed to be a gallbladder carcinoma. And the take-home message is grossing tells us the pathological stage of the tumor, site of the tumor and extent of the tumor. Know your anatomy before grossing. Approach the specimen in a stepwise manner. Always take a photograph of fresh specimen and fixed specimen before dissecting. And yeah, make sure to always take a photograph. That will help you a lot. Search diligently for the lymph nodes and peripancreatic fat. And suggested reading, there are lots of wonderful books, and you can get a lot of stuff online. And grossing of surgical oncology specimens, Tata Memorial Hospital, everyone will be having that book, I guess. We get a lot of information from that, and atlas of surgical pathology for grossing, and manual of surgical pathology. And thank you for a patient hearing.
Excellent talk.
We are not able to hear.
Yeah, excellent talk, Dr. Padmaja. Any questions?
No questions in the chat box. I think I would like to comment, at least in GI oncological specimens, I think there are two more very interesting specimens that one we get to gross, one being the Whipples, the other being the APR. And the Whipples initially might seem very intimidating, but once you get the hang of the anatomy, I think it's a very interesting specimen to gross. And yes, the Tata Memorial Manual, grossing manual elucidates it very, very nicely. And I always use it for grossing. And if Mukta ma'am is online, I think we have to thank her for that. Both the specimen, I think APR and Vipul have been very well explained. The grossing has been very well demonstrated in the Tata grossing manual.
Actually, I have one question for Mukta ma'am. Ma'am, actually, I was going for liver resections. They say you need to weigh the liver before grossing. And I could not find the reason why we should weigh the liver, particularly explant or partial hepatic tumor.
The reason for weighing is basically not for the oncology purpose, but it is for documentation of the residual liver mass, and also the documentation of how much liver is remaining, and then to also correlate with the functioning FLR, the functioning liver remnant.
Yeah.
So I think that is the significance of weighing and also assessing the volume of the liver. It doesn't have oncology significance like it has in, for example, certain tumors like adrenocortical tumors.
Yeah.
But that's the significance. Maybe Avani has something to do. Is Avani still there? Has she?
Yeah, I completely agree with you. We weigh every single liver specimen, whether it's a partial hepatectomy or a total hepatectomy. And I think the reason is not so much for oncologic purposes, like you said, but just to maintain uniformity. So for medical liver situations, we make it a habit so we don't forget to weigh it when it is important that the weight is documented. So it's a part of our grossing protocol for liver specimens.
Yeah, and it's a very good correlate for the radiologist also, where they and the surgeons where they calculate FLR.
Yeah,
so it is a good correlate.
Yeah. I just want to quickly add one thing about the weight. So if you are going to weigh it fresh, that gives more information. Once it has gone in formalin, it can still give you information, but then it's better to document that the weight is measured after the specimen is fixed, because that will give a higher value.
And just one very small point, Padmaja, that we do not really probe the ampulla and the bile duct in all specimens. It can be risky. You might dislodge a small adenoma lying in the ampulla or even in the duct. And when we bridle off the entire specimen, all relations become very, very well evident. So you really don't have to probe it.
Achha. Okay. In all specimens, ma'am, or for some specimens?
In all specimens, we don't usually do it. And if it is a periamp tumor, it invariably involves the terminal CBD, and it is constructed and obstructed any which way. So you might create a false track, and it doesn't serve much of a purpose.
Okay, okay, ma'am. Thank you. I'll make a note of it, ma'am.
But good presentation. Quite, you had worked a lot.
Thank you, ma'am. Because I was just wondering whether I've included everything or not, but I thought it's basic surfaces, because it almost took some time for me also to learn, and on the specimen.
Anatomy is the biggest challenge.
Yeah,
then you can identify the SMA group. You feel like really
yes. Used to have like
the clips are the clue. The clips.
Right. And many of the times, ma'am, it becomes sometimes very difficult in private practice.
Yes.
It becomes difficult to identify the CBD, the cut margin of the CBD. Sometimes it will be mashed up, and sometimes it will have all kind of surfaces. So I started asking the surgeon to please put a suture or something or ink over there. I faced a lot of difficulties identifying the CBD. Rest all okay, but especially CBD and pancreatic neck margin also. Sometimes it became very difficult, and I think multiple times going through the Tata manual, it was really, really helpful. but still on the specimen, working of the specimen, it may take some time, spending time with the specimen. And initially we used to have like goosebumps, where is the tumor, where is, especially in that intraampullary tumors, it becomes sometimes very difficult to first show the tumor to the surgeon. Here the tumor is there, size is so, and then comfortably we can sign out the report, I guess. And please add on, ma'am, if I've missed something or some in the process.
No, I think that was a good presentation. Thank you.
Renuka, you continue. Renuka, please unmute yourself.
Thank you, Dr. Padmaja ma'am, for excellent presentation, and thank you, Dr. Mahesh Deshmukh sir, for chairing this session. Now, lastly, this is time for interesting case presentations by VAP members. I request Dr. Sandhya Pokri ma'am, who is Associate Professor at GMC Nagpur, and Dr. Nisha Mishra ma'am, who is Assistant Professor at Department of Pathology, AIIMS Nagpur, to chair the sessions. First, I would like to invite Dr. Komal Galani madam, who is Director and Consultant Pathologist at Star Super Specialty Hospital, Nagpur. Dr. Komal Galani ma'am.
Hello.
Ma'am, are you there?
Yes, I'm there.
Yeah, I will stop sharing the screen.
Yeah, we have Dr. Sandhya Pokri ma'am and Dr. Nisha with us.
Good evening, everyone. At the outset, I would like to thank Dr. Prachi and the entire team of VAPM 2021 for giving me this opportunity for a wonderful case presentation. This was a 56-year-old male, an immunocompromised host, who presented with vague complaints of generalized weakness, loss of appetite, weight loss since 1.5 months. Patient had also had generalized swelling with abdominal distension. But the recent complaint was he had an irrelevant talk since last 1 week. This patient was being treated as a cirrhotic patient with portal hypertension and was referred to a hospital for further management. Past history was really significant since patient had many medical illnesses. Is hypertensive, chronic liver disease, has portal hypertension, was hypothyroid on medications for interstitial lung disease. One of his reports did mention as having anti-nuclear antibody positive, and recently was being treated for hyponatremia. Patient on examination was conscious but was disoriented and irritable. Vitals showed a pulse of 117 per minute, a blood pressure of 138/92. Respiratory rate was 18 per minute. Abdomen was distended with hepatomegaly, significant. However, there were no flaps. We thought the patient was in encephalopathy, but the patient didn't have any flaps, and there was no splenomegaly or any palpable lymphadenopathy. On blood investigations, a hemoglobin was 8.4, which was moderate anemia for the patient. TLC count was maintained 10,800 with a neutrophilic differential. There was thrombocytopenia. Urea was 75. Kidney was slightly altered. Creat was altered with 1.9 mg. Of note, in the LFT was elevated enzymes SGOT, PT. Though the bilirubin levels were normal, alkaline phosphatase was significantly high, which indicated significant compromised biliary ductal function. A clinical differential of pancreatitis was also suspected, hence amylase lipase levels were sent and those were elevated. CRP was also elevated, 102. LDH was significantly elevated, 1,235 units. Patient was non-reactive for hepatitis B and C. Since patient was seropositive, the recent CD4 counts was 122 cells. This was the helical axial contrast CT scan of the abdomen and pelvis, which showed gross hepatomegaly of about 20 to 24 centimeters and multiple hypoechoic lesions. These multiple arrows indicate the lesions in the liver. The largest one was around 6 centimeters. The patient had this liver parenchymal disease with multiple hypodense lesions. They were not SOLs, but they were hypodense on the radiological imaging. Spleen was normal in size. There was tiny old healed calcified granulomatous lesions, and there were multiple tiny intra-abdominal lymph nodes which had matting. The CT scan guided liver biopsy was sent to us. The HNEs, various HNE stain sections showed basically a diffuse lesion, diffuse monomorphic kind of lesion, where we had predominantly a lymphoid, monotonous appearing lymphoid cells. These cells at a high power were having multiple small nucleoli at the periphery. There was also what was seen is nuclear debris apoptotic bodies. However, classical starry sky appearance was not seen. We had a working differential of high-grade non-Hodgkin's lymphoma, a DLBL, Burkitt's, blastic lymphoma, or were we dealing with a double or a triple hit lymphoma? We had IHC to our rescue. The tumor cells showed strong diffuse CD20 positivity, along with positivity for CD10, BCL2, and the MIB1 proliferation index was high, around 90%. The negative markers include CD3, CD5, TDT, which excluded the blastic lymphomas. Finally, we rendered a diagnosis of primary hepatic lymphoma, which is a non-Hodgkin's lymphoma of B cell type, the commonest being the diffuse large B cell lymphoma. However, we also advised a c-MYC translocation for the patient. The bone marrow examination as a part of staging marrow was done, and it showed an uninvolved marrow. Just a point here, my radiologist had already insisted as this being a case of primary hepatic lymphoma, because such isodense lesions are highly suspicious of a primary hepatic lymphoma rather than any metastasis or a multicentric HCC. Patient was administered chemotherapy given on the reports. Patient was administered COP therapy first cycle, but his condition worsened with progressive renal failure, and he was put on mechanical ventilator. Finally, he succumbed within 15 days of initiation of therapy. Just a brief discussion on what is primary hepatic lymphoma. This case was first described in 1965 by Etta et al. This is a very challenging entity because initial review and case reports have given a very vague definition. Even the WHO classification doesn't have a primary hepatic lymphoma in its described entities. This is basically a lymphoma which is confined to the liver without any involvement of other organs or leukemic changes in the peripheral blood for at least 6 months after the diagnosis. Liver is commonly involved secondarily as a part of systemic lymphoma, this is more common as compared to primary hepatic lymphoma. This is a rare disease accounting for only about 0.4% of the extranodal NHLs or 0.016 of all cases of NHL. Basically, it is because of the natural lack of abundant lymphoid tissue in the normal liver itself. This generally occurs in middle-aged men. Presenting symptoms are very non-specific, just in our case. However, the most frequent physical finding being hepatomegaly. Jaundice is seen in only about 5% of the cases. Radiological findings here could be very variable, from a solitary lesion to multiple lesions or SOLs. Majority of the NHLs of hepatic lymphoma origin are DLBL, B cell type. Due to a lack of specific clinical lab and imaging features, a definite diagnosis of PHL requires liver biopsy, which is compatible with lymphoma in the absence of extrahepatic disease. IHC studies are essential to determine the correct subtype. As on treatment, no consensus has been as of reported, but chemotherapy stands the basic first line modality of treatment. Prognosis without therapy is grim. Prognosis and management of PHL is different from either hepatocellular carcinoma or metastatic disease. Hence, it is essential to differentiate it from these diseases. Some take-home messages. This is an extremely rare disease with non-specific symptoms and variable lab and imaging findings. Differential, we have to include these in our differentials when we have nodular hepatic lesions. Basically, in these cases, we get normal tumor marker levels and elevated LDH levels. Histologic diagnosis sends a very important tool for definitive diagnosis. It is important to recognize primary hepatic lymphoma due to its chemosensitivity, which especially when started early in the course of the disease. Thank you very much. And any questions?
Congratulations, Dr. Koban. Actually, it was a very rare case and really nicely worked up. And I really must congratulate that you could see, I mean, you know, and there were no other lesions in the patient, right? Like no lymphadenopathy or nothing else?
There were no palpable lesions.
Okay.
And those in the CT scan of the abdomen and pelvis, which were reported as tiny lymph nodes, yes. I did consult my radiologist saying that why was not the seat of a primary lymphoma.
Yes, exactly.
He said since the nodes were very tiny, 0.5 millimeter or so within the abdomen, especially in a setting of immunocompromised patient with a past history of TB, and those were matted nodes. Those were more likely of tuberculous rather than primary lymphoma. And since we had granulomatous lesions in the lymph nodes and retroperitoneum, we thought, why not this as the lymphoma? But obviously this was non-caseating even on the radiological appearance, and the histology was very evident of lymphoma.
Okay, that was it. Okay, good. Congratulations once again. Ma'am would like to ask anything?
Ma'am, please unmute yourself.
Hello.
Yeah, now we can.
Dr. Kumal, can any other prognostic markers be done in these cases?
Ma'am, ideally, this patient should have undergone molecular testing, the different subtype of DLBLs. Like today, even before reporting DLBL, we have to rule out a high-grade lymphoma with CMYC, BCL2, BCL6 rearrangements, both on cytogenetics or by FISH, because these are double expressors on IHC, but they do not indicate the underlying molecular markers. It is only with further molecular studies are we able to identify high-grade lymphomas. But however, due to financial constraints, we were unable to send the material for molecular testing. And since the patient died, we lost the material also. The relatives were not ready for any workup.
Yeah. It was a widely spread tumor, although primary in liver, but the tumor bulk was quite.
It was a bulky tumor in the liver itself, though till that time the marrow was also uninvolved. Marrow was also uninvolved.
Okay. Thank you. Very well presented. Congratulations.
Thank you.
Thank you, Komal Galani ma'am, for very interesting case presentation. I would like to invite Dr. Manjit Rajput ma'am. She is a consultant at HCG Cancer Hospital, Nagpur, for the case presentation. Manjit ma'am.
Just a moment. I would like to congratulate Dr. Prachi and her team for this excellent slides, for this excellent session today on pancreas and hepatic tumors. I would also like to thank Prachi to give me this opportunity to present this case. Am I audible?
Yes, ma'am, you are audible.
Yes, ma'am, you are audible. Thank you. So I would like to present two short cases. My first case is, it was a 55-year-old male who presented with abdominal pain in the right hypochondriac region, which was referring to back since 3 to 4 months. He also had loss of appetite and weight loss in 6 months He complained of high colored urine and vomiting on and off. On general examination, pallor and icterus was noted. There was no hepatosplenomegaly or no palpable abdominal lump on local examination. Imaging showed on USG an ill-defined mass at the head of pancreas with dilated common bile duct and main pancreatic duct. CT scan revealed a 6.7 into 6.4 centimeters large soft tissue lesion in the second and third part of duodenum and head of pancreas, obliterating the distal CBD and pancreatic duct. There was dilatation of the intrahepatic biliary radicals, the CBD. The lesion was infiltrating the duodenal mucosa, consistent with the primary neoplastic etiology, most likely arising from duodenum or head of pancreas with local infiltration. No peripancreatic lymphadenopathy was noted. CBC was within normal limits. The renal function tests were also within normal limits. The LFT was deranged. Bilirubin was slightly on the higher side. It was 2.6 milligram per deciliter. It was a conjugated bilirubin predominantly which was raised. SGOT and SGPT was also elevated. Alkaline phosphatase was also elevated with GGT, and the total protein was normal. There was no AG reversal. Serum calcium was 9.3 milligram per deciliter, which is also normal. And all the tumor markers like CA19.9, CEA, alpha fetoprotein were within normal limits. FNAC did not yield any diagnostic material for evaluation, so CT-guided percutaneous core biopsy was done. The pancreatic biopsy, you can see the core, it was a very cellular core. And on a closer look, you can see that there is dense and diffuse infiltration by these monomorphic looking cells. You can also see the residual pancreatic acinar glands, and they are infiltrated by these monomorphic cells. On a closer look, you can see that these monomorphic cells, they are plasmacytoid in nature. They have an eccentric nucleus, which is having condensed clumped chromatin, and they're having an amphiphilic cytoplasm. There was no evidence of mitosis. You can see the residual acinar glands here, and they are all infiltrated by these monomorphic looking cells. They were not looking very atypical. There was very low grade atypia. There was no evidence of necrosis. It's a similar picture. You can see all these glands infiltrating the pancreatic parenchyma. So considering these plasmacytoid cells, the first differential diagnosis was pancreatic neuroendocrine tumor, because plasmacytomas are very uncommon in the pancreas. So if you have any plasmacytoid cells in the pancreas, you should consider it to be a pancreatic neuroendocrine tumor unless proven otherwise. My second differential was plasmacytoma, which could be a primary or a secondary plasmacytoma. Of course, NHL also comes into the differential diagnosis, especially the plasmacytoid variant of the extranodal marginal zone lymphoma. Lymphoplasmacytic lymphomas also show these plasmacytoid cells. And of course, plasmablastic lymphoma is also a differential, although the cells were not looking very atypical, like as seen in plasmablastic lymphomas. So immunohistochemistry was performed. CD138 was strongly and diffusely positive. MUM1 was also positive. Kappa light chain restriction was noted. You can see this kappa is showing very good positivity. MIB1 index was around 30%. So the negative markers were cytokeratin, CK7, CK20. It was also negative for synaptophysin, chromogranin A, CD56, which ruled out the possibility of a neuroendocrine tumor. CDX2 was also negative. CD19, 20, and CD45 were all negative. This rules out the presence of non-Hodgkin's lymphoma. And kappa light chain restriction was noted. And MIB1 labeling index was 30% in areas of highest proliferative activity. So the IHC was suggestive of extramedullary plasmacytoma. So further workup was done to rule out whether it is a primary or a secondary. So bone marrow examination was done, which showed a normocellular marrow with normal maturation of all cell lineages. There was no increase in the percentage of plasma cells, so the bone marrow was not involved. End organ dysfunction features, which are denoted by the mnemonic of Crab in multiple myelomas, like hypercalcemia, R for renal insufficiency, A for anemia, and B for any bony lesions, they were all absent. CT scan was done and normal skeletal survey was done, and there was no osseous, or any other identifiable soft tissue lesion on CT scan. So serum protein electrophoresis was done, and there was a sharp monoclonal M protein spike, which was noted here. It was a very small spike, which is of only 0.44 grams per deciliter. Immunofixation was done, and this monoclonal gammopathy was of IgA and kappa type, and serum kappa light chains were also elevated. So the International Myeloma Working Group has set down certain criteria for the diagnosis of solitary plasmacytomas, and they are as under. If your tumor should be biopsy proven, and it should be consisting of clonal plasma cells, like in our case. The normal random bone marrow biopsy should show no evidence of any clonal plasma cells. The skeletal survey should be normal on MRI or CT scan, and there should be absence of any end organ damage, like what I've already mentioned. There should be no hypercalcemia, renal insufficiency, anemia, or any other bone lesions which attribute to a plasma cell proliferative disorder. There's also another entity which states that solitary plasmacytomas, if they have less than 10% clonal plasma cells in the bone marrow, they can be labeled as solitary plasmacytomas with minimal bone marrow involvement. So a final diagnosis was a solitary extramedullary plasmacytoma of the pancreas. So just few slides on plasmacytomas. Plasmacytomas can be primary, they can be solitary without multiple myeloma, or they can precede multiple myeloma. They can be secondary as a part of plasma cell myeloma, or they can, in treated cases of multiple myeloma, they can be the first sign of recurrence. And solitary plasmacytomas are of two types. They can be solitary plasmacytomas of the bone, or they can be extraosseous plasmacytomas. Like in our case, they can be present in any of the soft tissue or the organs. So extramedullary extraosseous plasmacytomas, they're very uncommon. They form only 5% of all the plasma cell tumors. The most common site, they are seen in the nasal mucosa, in the mucosa of the upper respiratory tract. And the most common site in the upper respiratory tract are the nasal mucosa, the paranasal sinuses, followed by the GI tract. 10% of these lesions are seen generally in the stomach, and followed by the reticuloendothelial system, like the lymph nodes or the liver. And of course, then in the pancreas, breast, thyroid, lung, and so on. The median age of presentation is 55 years, which is 10 years younger than multiple myeloma. And they are predominantly seen in the male population. And 20% of these cases show small monoclonal protein band, preferably of the IgA kappa type, like it is seen in our case. And no clinical features of plasma cell myeloma are present. Of course, they have a good prognosis, but if the tumor size is less than 4 centimeters, if the age is less than 50 years, and if they are present in the head and the neck, head and neck site, then they have a better prognosis. And if there's an absence of a serum monoclonal band, still they have a better prognosis. So solitary plasmacytomas of pancreas are again very rare. They form less than 0.1% of all the pancreatic tumors. Infiltration of the pancreas by the myeloma cells was seen in a case study where only 2.3% infiltration by these myeloma cells was seen in the autopsy studies. They can present with abdominal pain and obstructive jaundice, and they can also present with acute pancreatitis. The most common site is the pancreatic head, followed by the body and the tail, and they can also be diffuse infiltration of the pancreas with these plasma cells. The radiological findings are very non-specific. You cannot differentiate on CT scan or on USG from the other lesions, primary lesions of the pancreas. And for diagnosis, you have to prove the monoclonality of the plasma cells, either by immunohistochemistry or by flow cytometry. It is very important to distinguish between the primary and secondary plasmacytomas because the prognosis and the management are very different. The isolated primary plasmacytomas of pancreas are very radiosensitive, so radiation can be curative. And the secondary plasmacytomas are to be treated with systemic steroids and chemotherapy. They have to be added. They have a worse prognosis and they have a higher recurrence rate than primary plasmacytomas. I presented this case because it is very rare. Only 64 cases of pancreatic plasmacytomas are reported in literature, and very few of them are primary pancreatic. You should always consider other causes of pancreatic head mass other than adenocarcinomas because the management is very different. And histopathology in IHC plays an essential role in the management of adenocarcinoma of pancreas in the diagnosis of pancreatic plasmacytomas, because the management is very different from adenocarcinomas. Although they are very rare, the pathologist must be aware of the existence of pancreatic plasmacytoma as the initial manifestation of myeloma if it precedes if it precedes multiple myeloma, and such cases should undergo a complete workup for multiple myeloma, as localized disease has better prognosis due to its good response to radiation, as I've already mentioned. These are the references. My second case is a 60-year-old female. She presented with upper abdominal pain for 2 weeks. She presented with loss of appetite and weight loss. And on general examination, there was no pallor, icterus, clubbing, lymphadenopathy, or pedal edema. She did not have any significant findings on local examination. But she had a significant previous history, which was she was operated for breast cancer 7 years ago. On blood examination, CBC, KFT, LFT were within normal limits. On radiology, she had a mass in the body of pancreas on USG, which was 2.4 centimeters, and she had a peripancreatic node, which was 1.2 centimeters in size. CT scan revealed a likely neoplastic diffuse hypoenhancing lesion, which measured 4.3 into 2.8 centimeters in the head and ancillate process of pancreas. It was infiltrating the portal vein, and there was also a portal cavernoma formation. Of course, no distant metastasis was identified. So CT-guided percutaneous transgastric true-cut biopsy of pancreatic mass was performed. These are the CT images. This is a coronal section showing pancreatic head mass here, which is abutting the common hepatic artery. And these are the axial CT images showing mass at the head of pancreas. There are multiple venous collaterals, which are due to the encasement of the portal vein. This is another image which shows mass in the head of the pancreas with so many collateral vessels. Histopathology showed there was dense and diffuse infiltration here in the pancreas. You can see the normal pancreas here on the right side, and here is the lesion. On a closer look, these cells were actually, they were columnar cuboidal with hyperchromatic nuclei and eosinophilic cytoplasm arranged in abortive tubular pattern. There was no evidence of any pancreatic intraepithelial neoplasia. On a closer look, you can see that these cells, they are showing moderate atypia. There was no brisk mitosis noted, and they are all arranged in abortive tubular to trabecular pattern, having moderate eosinophilic cytoplasm. You can see one mitotic activity in this active mitosis in the center. So the first differential diagnosis is adenocarcinoma. Now, was it a primary malignancy? Was it a pancreatic ductal primary, or was it a metastasis? So we searched for the past history in a more elaborate way, and we found that she was a treated case of breast cancer 7 years ago. She had an MRM followed by adjuvant chemotherapy. It was an infiltrating duct carcinoma. ER was positive, PR and HER2 were negative, and she had completed her hormonal therapy on letrozole for 5 years, and examination of the opposite breast, axilla and neck were normal. IHC was done, CK7 was strongly positive, GATA3 was also positive, ER was also strongly positive, whereas PR and HER2 were negative. KI67 also was showing 50% positivity. CK20 was negative, synaptophysin was negative, CA19.9 was also negative on IHC. So the positive markers were CK7, GATA3 and ER positivity with a score, Allred score of 8. And the negative markers were CK20, synaptophysin, CA19.9, PR, HER2 The Ki67 index was 50%. So the final diagnosis was metastasis of duct carcinoma in a known case of breast carcinoma. Liver, bone and brain are the commonest site for breast cancer metastasis. Only 28 cases of pancreatic metastasis from breast cancer are reported so far in literature. The prognosis of pancreatic metastatic disease is usually better than any primary pancreatic tumor. Hence, you should need to differentiate between the two. And IHC plays a very key role in identifying the metastatic nature of these lesions. The disease-free interval of 7 years, solitary pancreatic head metastasis from ductal carcinoma of breast leading to portal cavernoma formation without jaundice are the noteworthy features of this case. And this case emphasizes the need to maintain a high index of suspicion for metastasis in a long-term follow-up in breast cancer. It also demonstrates the necessity of a regular follow-up in cases of any cancer case. This article was also published in April this year, and these are my references. Thank you very much.
Anisha ma'am.
Yeah. Actually, I think it's a day of rarity. I mean, really, we saw very rare cases, like, breast metastasis in pancreas and primary pancreatic plasmacytoma. And Manjeet, both cases were really very nicely worked up. So congratulations, and I can just congratulate. I really have no questions. I mean, they're so elaborately worked up that I really have no questions. Pofri ma'am, you can go ahead.
Yeah. Hello.
Yes, ma'am.
Dr. Manjit, what was the treatment and follow-up in your first case? Pancreatic plasma.
The patient, he was given 40 to 50 gray radiation, and then the patient did not follow up after 2 months. He has not followed up yet after 2 months.
Even local resection of the tumor is mentioned as a treatment.
If it is present in the tail or the body of the pancreas, local resection can be done. But in the head of pancreas, it is a little difficult. And I think since they are very radiosensitive, you can also go for SBRT. Stereotactic radiosurgery can also be done in these cases. So he was given radiation in our case.
Your both cases are excellent, very rare, and very well worked out. Congratulations.
Thank you.
And I thank the organizers, Dr. Prachi and Ankita, for giving us the opportunity to chair this session and hear such interesting and very rare cases. Thank you, Team VAPM.
Thank you, ma'am. Yes.
Thank you. Thank you, Manjit ma'am. Yes, ma'am.
Thank you to the whole VAPM team and Dr. Prachi for this wonderful activity.
Thank you, ma'am. Thank you.
Thanks again.
Thank you, Manjit Rajput ma'am, for very interesting and rare cases. Thank you, Sandhya Pofri ma'am and Dr. Nisha Mishra ma'am for chairing this session. Now, I would like to call upon Dr. Ankita Tamne, who is Secretary VAPM 2021-22, to deliver the vote of thanks.
Good evening, everyone. Thank you so much for attending this webinar in such a huge number. Like I was just looking at the number of the attendees, and it was like it is extensive. So first of all, I would like to thank Dr. Avni Paintse ma'am. She agreed to deliver the lecture and to be the guest speaker for today's webinar. And I'm really thankful to you, ma'am, for making up so early in the morning, and that too live from North Carolina. I mean, it's really like Mukta ma'am was very concerned, like how could she make up so early? And then I had to ask Prachi ma'am, yeah, okay, it's 7 o'clock. So thank you so much, Avni ma'am. And thank you, Ravi sir, and thank you, Mukta ma'am, for chairing the session. Thank you, Dr. Prachi ma'am, for having this innovative topic in mind to organize this webinar. And yeah, obviously your talk was extensive and amazing talk. And thank you, Kamyani ma'am, for chairing that talk. Thank you, Padmaja ma'am. Grossing of hepatopancreatic neoplasms is really very taxing and very tricky, but you delivered an amazing lecture on that. And obviously Mahesh Deshmukh sir, like he's expert in that, so he definitely gave amazing inputs. Thank you, Manjeet ma'am. Thank you, Dr. Amit Agrawal sir. Amit Agrawal sir is a renowned gastroenterologist of Nagpur. He has extensive experience, and his talk really threw quite some light in the gastrointestinal pathology workup. Thank you, Prashant Bhandarkar sir, for chairing the session. Thank you, Manjeet ma'am. Thank you, Komal ma'am, for presenting such interesting cases. And thank you, Nisha ma'am and Dr. Sandhya Pofri ma'am, for agreeing to chair the session for case presentation. Thank you, Renuka, for managing the entire webinar. I was not present in between. I had to just go on and off. Thank you so much. And last but not the least, thank you, Mr. Piyush from DigiShield for making this webinar possible. Thank you so much and have a great weekend. I hope I have not missed anyone. And obviously, thank you, Team VAPM. Thank you, Dr. Prajakta and Dr. Fatima. They have worked really well and took a lot of efforts to get the MMC credit points. Thank you so much.
And all those who opted for MMC points, the certificates will be sent to your emails in a matter of 2 to 3 weeks. Thank you everyone for joining. Hope you all enjoyed the session. Thank you.
Thank you. Bye-bye.
Piyush, are we live?
Yes, ma'am.
Can you stop the live now?
Okay.